Gross will be speaking at the World Dental Congress in China. Just a personal note, he is speaking on integrated care. My son was in the hospital for 32 days between June and December of last year, and we had several interprofessional colleagues working on his case, and one of them was a specialty in integrated care. And it was the integrated care doctor that pointed out to us the possibility of a parasite could have started the colitis and then exacerbated it with C. diff. So integrated care is a topic that's not well understood, but it has a very high importance. So let's welcome Dr. Gross.
So I wonder how many dentists here are in private practice? Could you raise your hands if you're in private practice? Great. So it's mostly an academic audience, and my lecture is toned toward private practice. I'm going to teach you a model of dentistry that I think is the future. Some of the speakers have talked about diet and changes of lifestyle of being important, and I'm going to go a little further with that. But basically, I'm in Tribeca in Lower Manhattan, and I've been doing this for over 30 years. My practice is $2 million a year, and I work 3 days a week. So as private practitioners, if you're looking for a model that will attract a really high-end clientele and not lock you into the PPO or DMO or whatever your country's government dental plans use, as a very international clientele I've noticed, but in every case, we as dentists are still businessmen if we're in private practice. And so if you are going to work in a fee-for-service practice, you are competing in the world now, and you have the choice to discount your services through some kind of insurance plan you join, or you can go for a high-fee, high-quality environment where you can really interact with that patient and learn to do something more quality. So hopefully this will be stimulating to you, and you will learn terminology that in the world of the internet now, when patients come up to you and say, do I have a cavitation, or is there anything wrong with mercury? You don't just turn around to that patient and say, you don't know what you're talking about, I'm the doctor, because that's the quickest way to lose a patient, particularly a well-educated, cash-paying patient. So hopefully today, if you come away with nothing else, and you don't even believe me, that there's opportunities out there, you're going to learn some new terminology so that when that patient turns around to you, you at least can, a little light will go off in your mind and you'll say, well, I understand what you're talking about, and hopefully you'll learn to address it. Now, I'm going to be giving this lecture in 2 weeks at Columbia to the dental school. I've been an alumni there for 30 years. It's taken them 30 years to allow holistic dentistry into the American dental schools, which has been very frustrating because I've been knocking on that door for a long time. But we had a new dean, and he's claiming that he's going to be more open to new paths for the university, and giving that lecture soon. The schools are changing, though. NYU has now recently dropped mercury from their curriculum, and it's only too soon because schools like Columbia are teaching mercury still for a public that, to my knowledge, in America, nobody wants mercury fillings. So why are you teaching students things that they're never going to use? Hopefully you're going to learn terms about BPA, which we all know as bisphenol, which is in many composites. Many patients go and ask their dentist, can I have a BPA-free composite? And the dentists look at them and don't even know that BPA is in their fillings or in their partial dentures or in their full dentures. And that the possibility exists that you can have laboratories and companies like 3M manufacture BPA-free materials. In fact, the companies were well aware of BPA, which is in plastics and bottles, and as it heats up, BPA volatilizes and is considered an estrogenic agent, meaning it can change the testosterone levels of children. Yet it's used in sealants. Sealants have the most BPA of any composite because it's a volatile product. Why are we putting BPA in children? So 3M and many of the other companies now are changing over to BPA, and it's a simple thing when you buy your products to ask the manufacturer if they're BPA free. You will also learn about sleep medicine, alternative treatments to periodontal disease using things like ozone irrigation, and an integrative practice. So an integrative practice not only has regular dentistry. I have 6 other dentists who work with me of all the different specialties, but I've got 4 other holistic healers who do things like cranial sacral, lymphatic drainage. In the past, we've had acupuncture, and we do nutrition. Dentistry is changing, and we are educators, but hopefully we're educating toward the future and not just repeating the same information about mercury and things that the dental profession has been using forever. The world is changing, and medicine is changing rapidly in this country too. I'm addressing this to my understanding of American-trained dentists, and correct me if I'm wrong, that in the world it's the same thing. If you're dealing with an educated population, they're in medicine, it's the same thing. They're looking for functional root cause resolution of disease, where you use preventive procedures and not wait until the disease is fixed. In dentistry, that means we're not going to be carpenters anymore of teeth or just tooth carvers. We're actually going to be doctors of the oral cavity. So that implies that we are responsible for doing oral cancer screening. And I would say the most powerful thing you could come away with today of what I'm going to talk about is what makes me a holistic dentist is, I'll tell you a story. I don't know if you know the actor William Dafoe. He's been out there a long time, probably in a lot of Batman movies. He's a very famous actor. And he came to my office recently, and I said, why did you want a holistic dentist? And he grinds his teeth, and he's looking up. And then he says, doctor, because of your intentions. And to me, that was so powerful. Why are my intentions any different than any other dentist out there? And as I thought about it, I sort of made some sense, because just after him, a patient comes in who's a new patient who came in with a deep cavity and a virgin tooth. The previous dentist looked at that x-ray and immediately said, you need a root canal. Well, the patient didn't want root canal. Root canal's getting bad press. We'll talk about that later. So the patient came to me, and I excavated it, put an IRM. Tooth was been a couple of weeks later, filled the tooth with a composite, and the tooth was healed, and the patient was very happy. Patient comes in all the time saying they told the dentist, I don't want mercury. The dentist look at him and say, shut up, you stupid, I'm the doctor. And the patients come to me. If you continue as providers to do the same old model where you are the doctor and the patients are the victims, you're going to lose your business. And yes, you can discount your business till you're giving it away for free, but as a dentist, we have the same obligation, the same clinical need and effective malpractice, whether we're getting paid $1 or $1,000 for that procedure. So why not get paid $1,000 and do it well? And to do that, you have to educate your patients. You have to not just pull out the drill or the injection. You got to spend the first 15 minutes shutting up and listening. So I consider myself a tooth whisperer. So the first thing I do is just listen to people, and rather than shouting at them that I know the diagnosis and this is what you have to do, I just listen to them, and I think that's a great thing. Another thing is that we as providers, we're dealing obviously with humans, people have said that, who have their needs, and to do that with love and caring. For instance, one of the doctors recently in my office, Dr. Verma from India, a patient came in who had cracked her front teeth on the ice. New York was very cold last year. She slipped, broke her front teeth. Dr. Verma made some beautiful crowns for her and then sent the woman flowers. She sent the woman flowers. And the patient was like, my God, this is the first time a doctor of any type has ever shown love and caring. We can all make great crowns, hopefully, but this is the first time that a doctor showed some real sense of caring. So I really believe that intentions and the way we present is a future model, doctor, of how dentistry should be, although I appreciated your points. Some of the things we're going to talk about, of course, the oral systemic connection. That's gotten a lot of press about the microbiome, that the mouth is the portal to the digestive system, and that depending on what you eat and diet can affect the way that digestion occurs, and that overuse of antibiotics is affecting everyone's general health and destroying the good. And there is a lot of use now in prebiotics to help treat periodontal disease and general digestive health. There's what's called the inflammatory model of general medicine, which is that things like infected root canals or toxins like mercury or digestive diseases like the doctor who introduced me inflammatory digestive diseases can set up further diseases down the road in an inflammatory model for your whole body, leading to autoimmune diseases, cancer, heart disease. And we all have heard about how dental infections, chronic dental infections, can lead to heart disease and low birth weight babies. So we know there's a definite connection between the mouth. You can't separate the mouth. Dentists have been putting blinders on their whole career so they could focus on that little tooth, when in reality they've lost focus of the product that there is to patients. Another thing is acid-base buffering. I think the saliva is your natural environment, and we don't give the saliva enough credit for keeping our mouths healthy. But because of the modern Western diet, and we're going to talk about diet later if we have time, we have become very acidic. I measure every patient's saliva acidity every time they come in and keep a log of that to see what their profile. Normal saliva should be about 7.2. I find on average it's about 6. And salivary acidity is leading to a lot of other medical conditions. It leads to periodontal disease. It's a marker of your general body chemistry. It can also be a marker of diabetes. It shows it can lead to erosion. In this new world where we grew up on fluoride in America, the kids, I'm finding that mostly what I've done for 30 years as a dentist has been to replace my own work or other dentists' work. You know, basically doing the fillings over, which lead to root canals or crowns, and then periodontal disease. There's that whole model of invasive dentistry. It almost feeds itself. And you know, the crowns don't fit perfectly. There's a little open margin, which then creates a periodontal defect. And if they had virgin teeth, because under 30-year-olds now in America are all growing up on fluoride, and they generally don't have that much decay. It changes the whole business model of dentistry. So dentists, yes, we're doing implants, but basically what are the dentists? I tell my students at Columbia that you may be the last generation of dentists in America, because as you age, what's going to be left? Trauma, a little orthodontic work, and maybe a little perio, but basically there's no more crown and bridge. So you've got to grow with this, and we have to learn that we are treating the whole body, and we're going to talk about things like sleep medicine and how that's a nice new profile for dentists, and facial development. I'm involved with sleep medicine studies in young adults. They find that student behavior and child behavior and development is based on lack of sleep, and that if you do expansion orthodontics, where you open the airway, you get mandibular protrusion, which opens the airway, and good facial development, which goes against all the orthodontic techniques where they used to extract premolars and squash everybody in and close the airway and cause TMJ, and all the iatrogenic dentistry that's been done when I was learning about it. And we're also going to talk about simple things like detoxifying, which you can do with coconut oil pulling. The mouth is a very transient place for drugs to go in and out. You know, you can take sublingual drugs. When you do oil pulling, you generally use coconut oil, but you could use other oils. Basically, you swish it around. 5 minutes is good enough, and then you spit out, and it pulls some of the toxins out. Some of what you're going to learn today is just about giving informed choices to the patients, and that education. What I suggested is if you want somebody to pay above their PPO schedule, that's something that's used in America. That's like a middle level of insurance where the dentist agrees to like a 50% cut in his fee, but he's put on a list to get business. But how do you get patients like that then to pay? A lot of them just expect that you're just going to work off the insurance. So it's difficult for American dentists to create value, then get patients who really want good work. And you can do that by educating your patients into the dangers, for instance, of the mercury amalgam. Many dentists will take out the amalgam because it's cosmetic, but only 10% actually follow the protocol that's been established by the Holistic Dental Association. Now, every dentist in this room knows how to do it. The most important thing you got to do is use a rubber dam. If you use a barrier when you take out a mercury filling, you're doing the main thing you can to prevent exposure. It's good to put some eyewear on the patient, some nose cover, have good suction, try to take out the mercury in chunks. But the main thing is not to vaporize it and let them swallow all that mercury that gets in their mouth, and they rinse into the sink and they look at all that black stuff that we know that's coming out. And to protect our own staff, to use masks, air filters in the office. It's proven that the more mercury fillings you have, the higher your blood level of mercury. So the ADA's position right now on mercury is that there is not enough proof that dental fillings cause disease from the amount of mercury we're getting, although the amount of mercury in the American public is astronomical right now. There was a recent study of placentas in children that found 6 times higher levels of mercury in placentas, and children are much more exposed fetal to mercury. Of course, in the new world, you can do things like check compatibility to allergic patients. The ADA says it's okay to remove mercury if the patient's sensitive to mercury. Well, that's sort of idiotic because everybody would be sensitive to mercury, but if they're sensitive to certain metals, like they can't wear not gold, there is a company called Clifford Reactivity Test that does a simple blood test and it can determine whether your patients are allergic to every dental material, and we'll send you the book, and it's a simple test they can take. Another thing is, of course, we should use digital x-rays. I don't know if anybody's familiar with infected root canals, but basically my opinion on root canals is probably 50% of root canals are unnecessary. Once again, the classic situation, the patient comes in, the dentist already has a preconceived notion that that tooth is going to be a root canal, and they don't make any effort to try to save it. Or the tooth has already come in with a long-standing periapical lesion, and then they do the root canal. And the success rate long-term of an infected root canal is very poor. As we all know, the anatomy of a tooth's got thousands of microtubules running through it, and just cleaning out the main chamber, there's no chemical you can put down that chamber. Even though we use ozone, we use lasers, none of it really cures that infected root canal. So what you're doing then is you're locking the bacteria in, which creates a medical problem long term. Patient may not have pain anymore, but you're locking the bacteria in, which leads to things like NICO. NICO is chronic necrotizing infections, and there's the foci theory of disease, that people can get long-standing diseases from these dead zones in the bone after the tooth's extracted. So I have a real problem with root canal, and as I said, one of the biggest advertising things that I do is alternatives to root canal, which is basically about intentions. And then when we do extract a tooth, we do what's called a cavitation. And cavitation is both a noun and a verb. It's that infection, that cyst that we know exists at the end of a root canal is a cavitation. But to clean that out and scrape out the socket and remove the periodontal ligament and all of that and scrape down to the bone, it's basically good surgical technique, is to cavitate the socket. And as far as bone grafts, I don't believe in any of the animal bones should be used, bovine, cadaver bone. We don't want any of that. We're using the platelet enhanced. So it's the patient's own blood. We draw blood from their arm, centrifuge it down, inject it back in the site. Patients love it. It's their own blood. It's like a blood transfusion of their own. You're not getting some pig bone put into your head. The other things we're doing is, of course, a lot of digital dentistry. Since I don't use mercury for 30 years now, was never great with composite fillings, large composites. I found it was very difficult. And for a while now, I've been doing the CAD/CAM system. which of course is somewhat expensive, but there's a new one I'd like to recommend, which is the 3M scanner, which is an open platform, and you can use it for dentures and other kinds of restorative, but it will go directly to the lab. But I have great luck now with the Roland milling. It uses a lava block, and the whole system, you can get a scanner with a miller from Benco for about 40 grand, which is about a third the cost of the old Sirona, Ceric, and Henry Schein systems that are out there. And that's going to really save you a lot of money. The blocks are very inexpensive. The nice thing is the lava block is a hybrid material that uses both resin and porcelain, so it's more biocompatible than your strict porcelain. You can make crowns, single crowns, inlays, onlays. It's not fired, so it's not as cosmetic for laminates, but most dentists I know are not using Ceric for laminates. They're basically doing posterior restorations, and this works great. It's a small machine. It's a dry miller, so the installation is minimal, and it's a really good setup. So that's what I would go to if you were trying to get away from mercury. And of course, digital dentistry is, the future is maybe you're going to be online consulting. I'm looking into that right now because I get calls from all over the world. People say, "What would you do, doctor?" And they send me their x-rays. So I wanted to try to, by informing the patients, I feel like I can actually affect their treatment because they now, when they go to their dentist in, I don't know, pick a place, wherever, I obviously can't control the dentist, but by the patient being educated, they can control the dentist to some extent, their modality. I'm also talking about creating, the future wave of a dental spa as an alternative source of income. A lot of dentists now are doing cosmetics, but you can add things like Botox, not very holistic, but you can do a cosmetic spa. And we also, as dentists, are the front lines treating diseases. So maybe one day we'll be checking people's DNA and things like that through their saliva. There's a lot more tests coming out. But saliva should be as good an indicator of disease as blood eventually. So in an integrative practice, the basic plan is to use other kinds of healers as alternative sources of income and as a value addedness that patients come to my office and say, well, this is great. I can get acupuncture instead of an injection for a filling. And I've done 4 wisdom teeth with just acupuncture on a patient. Basically, I have an acupuncturist comes into the office. They have to administer the acupuncture during the procedure. As anesthesia, it only works really well for patients who've had experience using it before, but it can definitely work in a dental environment. And there are people who don't want Novocaine or anything. They've had problems with epinephrine. I generally use carbocaine, but in any case, it's an alternative. And acupuncture can be used for a lot of healing modalities to strengthen their immune system. We're also getting into facial acupuncture because I think as dentists, when we do orthodontic work, we do a lot of Invisalign. And we do non-extraction. We never pull premolars. We expand the arch, expand the face, elevate the dentition. It's like a facelift, and I've seen great results. And you do that with little facial acupuncture, and their faces tighten up, and you're not doing any, it's like plastic surgery. So that's a whole other cosmetic way. We use biofeedback to handle people who have TMJ, stress, anxiety in dentistry. Reflexology, there's this point right here in the middle of your hands. When you give, if you have your patient pinch that side where they're getting the injection, while you're giving the injection, they won't feel the pain of the injection. So they can use that for headaches, migraines. I also bring in health counselors who can help people with quitting smoking. And oral cancer we talked about is such an important obligation of dentistry to do oral cancer screening. I have a veloscope. I actually, brush biopsy is my favorite, CDX. I don't know if anybody does CDX here. I use it a little differently than it's decided. CDX came out of pap smears, and when they do pap smear, they scrape the wall, and they don't necessarily see a specific lesion. We're taught that we have to only do a brush biopsy when you see a lesion, but by then it's generally often too late. And Veloscope and Visalite aren't great. So I often more profile the patient. So anybody who's 50 years old, history of smoking, tobacco, heavy alcohol, immediately gets every 2 years a brush biopsy. And I choose what it looks like the most likely spots, but I've found oral cancer in patients who had no symptoms, nothing soft tissue, no spots, anything, and I feel like I've saved people's lives, and we should be doing that. And then, the health counselors can help support your program that you're trying to get if you're getting somebody to do better hygiene and stuff. The hygienists aren't always that good at, following up on that. We also use craniosacral. A therapist comes in, which is a very light touch, manipulate the head and plates. If somebody's getting orthodontic work, in real orthodontic work, you're actually manipulating the plates of the skull. So there's muscles and things like that that can be assisted to relax. And lymphatic drainage is one of my favorites. I have an oral surgeon, patient comes in half hour before they're having the wisdom teeth out. There's a special way to drain the lymphatic system where you clear it, you clear the lymphatic, drain the channels so they don't get the swollen lymph nodes. They're also, by doing lymphatic drainage for about a half hour before, it loosens up the facial opening. And a lot of the trauma of oral surgery is the doctor's and the assistant's hands in the patient's mouth. So if they're a little looser, there's a little more blood flow in there. Pre-surgery, they get better healing, and a week later they come back and it helps drain off that lymph node and stuff. So we do a pre and post lymphatic drainage. People ask, well, how do you charge for that? The health service people are on salary, and we do charge for it and sometimes I'll throw it in as a give it, just as a nice thing if somebody's got a problem. But we do charge for it. And other thing is myofunctional therapy, and I was talking about sleep medicine and how as dentists we can get so much involved with snoring and sleep apnea. I do a lot of studies on that, and we teach people different ways to speak, and we have functional therapies. So sleep medicine, I think, is a really nice future. The only treatments for sleep apnea are either surgery, which doesn't work, the CPAP machine. So if you have a sleep apnea, one of the doctors was showing the appliance that she constructs, which is a repositioner. That's sort of a standard product. I actually would prefer to do orthodontic work, like with Invisalign. So if we diagnose that they have sleep apnea, we put them through Invisalign. If we find that that's the problem, that they generally overclose, some overjet, overbite. And that's a permanent solution rather than being married to a sleep appliance, which you might throw in immediately. But in the dentistry, we have a lot of things we can do. We use homeopathy. We talked about how it's not what you eat, it's what you digest. And if you're going to, you have to support the good bacteria that's in the body with probiotics. And things like mercury actually are digestive disease weakening systems. Getting back to the root cause resolution, that we as dentists have an involvement with the medical health. Now, I do a holistic hygiene program, which you could all, if you're in private practice, institute. Of course, we do the scaling and root planing for anybody with a type 2 perio. We have a periodontist in the office, but for the hygienist, they do the scaling and root planing. We then use ozone irrigation. Ozone is a simple machine, costs $200. It puts basically O3 into water, and then we irrigate with an extra oxygen molecule because the anaerobic bacteria don't like oxygen. So we irrigate subgingivally, and we teach them to do it.
Doctor?
And you just make it every day. Go quick, 5 more minutes? Okay.
No. We're 5 minutes over.
Okay. And so we talked about the mercury, and just quickly, Weston Price was one of the most famous people in holistic dentistry, and he talked about diet being so important. And one of the things I heard, everybody knows about sugar and being no good. We were all taught on that. But there's a new thing called phytic acid they found, which is in grains and breads and all those things. And that actually, phytic acid blocks the minerals by reabsorbing, remineralizing your teeth because it makes you acidic. So if you want to remineralize early decay, and you were talking about that I think in the country you were talking before, you can do that by alkalinizing the saliva, and you can do that through more water, less dehydration, using alkaline water, and by reducing phytic acid by sprouting your grains. So traditional societies use sprouted sprouted wheat products as part of their fermented products. So that was part of their breads and stuff, always had sprouted. But now, with all the Western diet, everything's processed, killed. And that's actually making us sicker. So, that's a good thing to get involved with. And remineralization does work, but you have to check the patient's pH. And I am pretty much done. Thank you.
Okay. Thank you.
Okay.
Thank you.
Any
Doctor.
questions?
Let's thank the doctor once again, and I have a little something for you. Thank you. Our next presenter is Professor Ana Maria Griego from Pontificia Universidade Católica de Paraná. How'd I do? And an interesting presentation awaits you. So, Professor?
Good afternoon. Thank you, Doctor, for my introduction. I am Ana. I'm from Brazil. And before I start my presentation, I need to speak a little bit about my life. Because I am a pharmacist, but I work in a dental college. And I believe completely in the holistic treatment because I'm a pharmacist and I work with medicinal plants and homeopathy. And I know that this kind of treatments works is so useful in our life. And I have in the past insomnia and I didn't take benzodiazepinic like my patients. I don't take benzodiazepinic. I prefer acupuncture because it's really, really useful. Okay, when I finished my PhD, I received the invitation to work in a dental college. And for me, it's a kind of challenger because I'm a pharmacist. And in my master and my PhD, I work a little bit with medicinal plants. When I got the dental college, I made a map with my colleagues in a dental college, my dentist colleagues, which the main needs you have regarding pharmacology. And they said, we have something in common. Many patients come inside your clinic and they complain a lot about dry mouth. Okay, dry mouth. Why dry mouth increase this kind of side effect? Because nowadays there is this kind of disease in our society. There is depression. And depression is, according WHO, depression is the common disease and increase day by day in the world. And is the most common form of affective disorders. We can study about that, and for us, the community, the scientific community, we discuss about science, why increase depression. According to Dr. Leila, she said one morning for us, the students like a lot blog. The students like a lot website, media, Facebook. We have Facebook today, we have many kinds of social websites, and people speak with each other by mobile, by computer, but not more face-to-face. And I have some opinion about this. And many works in the psychology area said, we have too much, we get this increase, this number about depression because the lifestyle and technology helps, but sometimes disturb. And people speak, I can listen from my students, I have 1,000 friends, but you live alone in your house. I have 1,000 in Twitter, people that follow me, but you are alone in your house. I think so, it's my opinion. We have more technology, we have more hospitals, we have more medicine, more treatment, but we don't have health, at least in my point of view. Okay. Depression could be serious, and people can commit the suicide. According to WHO, the suicide in the world is 1 million deaths every day. It's too much. We need to take care about this because we discuss science. We are scientists. Scientists need to take care about this. Okay, why depression happen? At least in my point of view, and many articles, many papers discuss about depression. It's a kind of deficient some monoamines, like noradrenaline, serotonin, and dopamine. We today cannot have depression, but in the future we can. We can. Everyone can have depression during one moment in the life. For example, we can lose some people that you like a lot. We can lose some people in your family. You can lose your job, and you can become depressed. Okay, about the treatment. Now my aim is about the treatment. The adequate treatment is the drugs, psychotropic drugs, that increase the molecules, noradrenaline, serotonin, and dopamine in our brain. Okay, this medicine is involve antidepressant, antipsychotic, and anxiolytic drugs. There is 2 kinds of anxiolytics, benzodiazepine and barbiturics. I choose benzodiazepine because in my country, at least in Brazil and South America, people when complain about insomnia, anxiety, depression, it's a kind of depression, people cannot sleep very well and need to take this kind of medicine. And I work with 2 different kinds of benzodiazepines. I work with lorazepam and I work with midazolam. Why? They are BZD, benzodiazepine, but they have different kind of mechanism. First, lorazepam, there is a long bioavailability, and midazolam is a short bioavailability. When people complain about insomnia, it's common the doctor prescribe lorazepam. For us in a dental college, midazolam is useful. Previous the treatment. For example, when people need the surgery, before the surgery, the doctor, the dentist prescribe midazolam because people became calm and more cooperative during the surgery. It's common. These drugs, psychotropic drugs in general, is common. They present many kinds of side effects. Dry mouth, it's my study, dizziness, sudorese, and intestinal constipation. Wow. Hyposalivation, my focus. Hyposalivation, xerostomia, and alterations in a saliva composition. people can complain. I have dry mouth, but the amount of saliva is normal. The name of this is xerostomia, I mean. It's a kind of subjective sensation. People has inside the mouth saliva in a good amount, but they complain. And it's common when people start this kind of treatment. At least 6 months need to recover the level, the normal level of salivary gland, saliva production. Hyposalivation. According to many studies, hyposalivation is considered when the value of salivary flow rate, the flux of saliva in the mouth, is less 0.7. When our patients start this kind of treatment and they complain, this common side effect, according to I told, dry mouth. Why this happened? Until today, nobody knows. The mechanism is not clarified. I try discover about this. In the world, there is at least 3 groups that work with dry mouth and psychotropic drugs. There is here in America, there is a group in Japan, and there is a group in Europe. And I, a scientist from Brazil, start to work with this. Okay, this picture sometimes scares. The students doesn't like this because it's a pharmacology, pharmacodynamics, but it's important now. Because this picture, in this moment, make a connection for us why benzodiazepine produced dry mouth. Benzodiazepine works in the brain, of course, because diminish the anxiety. And benzodiazepine works in a GABA receptor. We have many, too much amount of GABA receptor in our brain. When our patient take benzodiazepine, this molecule act link with GABA receptor. This GABA receptor is in the brain, not only in the brain. God knows why, but there is GABA receptor in the stomach, there is GABA receptor in the intestine, and there is GABA receptor in the parotid gland. When the GABA receptor receive this molecule, increase the release of GABA amino acid. GABA amino acid increase the delivery of chlorette. And there is a hypopolarization. And there is no despolarization. If there is no despolarization, there is a block of neuronal cells. And there is a inhibitory effect. I think so because of that, when people take this kind of medicine, benzodiazepine, this kind of medicine works in the brain, a GABA receptor in the brain, but also works act GABA receptor in a parotid gland. One act in the GABA receptor in a parotid gland produces an inhibitory effect. I mean, there is no a good release, salivary release. Okay. Then a histomorphometric and gravimetric study can help discover about this cytotoxic effect of benzodiazepine on the salivary gland. I have two main aims. First, discover about the effect midazolam and lorazepam in a parenchyma of a parotid gland. I mean, in a tissue. Second aim, to investigate the role of the oral-based alkaloid. This alkaloid is from pilocarpine. Sorry, not pilocarpine, jaborandus. It's common, this medicinal plant in my country. Jaborandi, it's a kind of a tree common in South America. And you can extract this jaborandi pilocarpine. Pilocarpine is common to the treatment of glaucoma. Okay, in the world, there is no, if people complain about hyposalivation, the doctor cannot prescribe a good medicine. There is in America and in the Europe Salagen. But when people take Salagen, okay, the amount of saliva increase in the mouth. But people complain pseudoresis, people complain hypotension, the level of the blood pressure decrease, hypotension, and they complain about the intestinal contraction, sometimes diarrhea. Because this kind of medicine, Salagen, here in Europe and in US, is a systemic. The people take in a systemic form. I try to discover another way to apply pilocarpine, oral basis. I mean, it's a topical application. I have time? Okay. I work with animals. First, in my country, when you need to discover some new medicine, I think so in US is the same, of course. We need rules, respect some rules. We work with my patients. In this case, is my animals. After I have good results, I can apply in the human beings. Okay, I work with the Wister rats, the male Wister rats. This table shows us my study design. I work at least with the applying, administrate this kind of medicine during 2 months. I decided to work with, apply this kind of medicine 2 months in the animals because when people start this kind of treatment, delay, not insomnia, anxiety, didn't take 1 day, take at least 6 months. But this time in the world, in the life of the rats, is enough for us because 60 days in the life of the rats is like 1 month in the rats is equal 1 year in the humans. 2 months in the rats is equal 2 years. Because of that, I apply so long time. I have groups that receive saline to compare my positive control. I have group that receive pilocarpine, midazolam, and lorazepam. After the animals receive midazolam, they receive both midazolam, pilocarpine, my patent. Nowadays, I could deposit my patent. Now this formula, this medicine is a patent. And I treat the animals with the benzodiazepine plus my patent, pilocarpine. Okay, this histomorphometric works is according to this Eltor, Onofre et al. It's so difficult, this kind of study, because histomorphometric, it's a deeply study. There is too much statistician. Okay, my results. This table shows the group that receive S30 is saline, M, midazolam, L, lorazepam. N, it's mean the number of acinar cells. Why I study these acinar cells? Because if the amount of the saliva decrease in the mouth, the parotid gland didn't work. Why it didn't work? Because there is too much acinar cells, or there is no, the medicine block these acinar cells. In my case, I can discover that when the animals receive benzodiazepines, the number of these acinar cells decrease. I have some study nowadays in my lab in Brazil about apoptosis. Benzodiazepine can develop a kind of apoptosis in parotid cells, in parotid gland. And salivar flow rate, of course, when saline group is normal, and when the animals receive midazolam and lorazepam, you can perceive in the table decrease the volume. Size is the size of the parotid gland. The size of parotid gland increase, and the VC is cell volume, the volume of the parotid, and the volume of parotid increase. This table is so important for me because my hypothesis about the effect of benzodiazepine I can clarify with this table. I mean, the volume, the cell volume, the parotid gland increase because there is a hypertrophy effect of benzodiazepine. And if you have less number of acinar cells, there is apoptosis. And you have the increase the volume cell because there is a hypertrophy. It's mean for me, I think so, because when people take this kind of medicine, the parotid gland works. Parotid glands continue the production of saliva. But benzodiazepine block the stimuli. The release of saliva is blocked. Okay. Now I need be in a hurry. The animals that receive treatment during 2 months is important for us, LP and MP, because when the animals receive my patent, the pilocarpine oral basis, we can perceive that the volume cell is almost equal the animals that receive pilocarpine. Pilocarpine is an agonist, is a cholinergic agonist. Pilocarpine works in a muscarinic receptor and increase the stimuli. Then I can, from this study, I can confirm that when people complain about dry mouth, this side effect of benzodiazepine, produce saliva, but it didn't release saliva. And pilocarpine recover this status. Okay, this picture shows us A, it's a control group, saline, B, midazolam, and C, lorazepam. You can perceive that, I can have, but don't worry. You can perceive the organization is completely different. The parenchyma, the architecture of a parotid gland is completely different, and B and C when you compare E, because E is my control group. Okay, in a hurry. This picture is my favorite because according to this magnification, I can show you that control group, psychotropic group, and psychotropic group plus pilocarpine. In this magnification, you can perceive this and this picture is, there is things more similar than this group. Okay, to conclude, the chronic administration of midazolam and lorazepam proved to be able to reduce the parotid acne. Could be because of that reduce the salivary flow rate. And when you treat the animals with pilocarpine, my patent, you can reestablish the number of acinar cells and the restorative salivary flow rate. Okay. It's a kind of graphic abstract. Anxiety, benzodiazepine, dry mouth, pilocarpine, increases saliva. I'd like to give thanks for this organizing committee for accepting my abstract, my work. I'd like to give thanks for God because everything in my life that I propose, I get because God stay every time with me, my institution, and this audience because listen me. Thanks.
Thank you very much. I think we have time for a question or two. Dr. Gross.
Hi. Do you find that dry mouth leads to acidity in saliva, lower acidity?
If
a lower pH?
if I find dry mouth, sorry.
Yes. Does dry mouth lead to a more acid saliva?
Saliva.
Acid?
Acid.
Acidic?
Ah, the salivary composition, you mean?
pH.
Yeah. Yeah, we have not in this study, but you have we collect in the past we collected I have a paper that I published the biochemistry composition, the saliva change completely when the patient take benzodiazepine, include antidepressant. Yeah, the salivary composition is different drugs. It's more acid and different. And people can complain more. No, people has more caries. Caries, periodontal disease, aphthous, and K-lit. Okay.
Certainly, we have another one. Another question. Just a moment, please.
Have you tried using pilocarpine as a systematic drug instead of local administration? In this case, the effect on parotid and other salivary gland acini?
No.
You don't?
No, until today, I didn't try. I can. I can. Now, just this year, I'm here in US. I'm doing my post-PhD in this field in the Toledo University. And but now I work with Western blot, the expression of protein and Western blot, because I can close this cycle. I can close because I work in histomorphometric, immunohistochemistry, not in our study, but I have another study, and now Western blot.
Very good. Again, Professor, thank you very much for your presentation.
We'll now be hearing from Dr. Jihan Fikri, has obtained her BDS, her MSDS, her DDS degrees from Cairo University from 1987 to 1977. She is a fellow of UCLA in December 2000 in maxillofacial prosthodontics. She also has attained another MS degree from the Hospital Management from Arab Academy for Science, Technology, Maritime Transport in 2014. She is working at Minya University in Egypt since 1998, where she is conducting and supervising multiple researches that resulted in more than 45 MS and PhD theses. She is currently the Dean of Faculty of Dentistry in Minya University. She has published more than 30 papers in reputed journals and conferences.
Thank you for this presentation. Good afternoon. Longitudinal evaluation of different part designs in immediately loaded mandibular implants supported over dentures. Dentistry is the start or dates from the old civilization. Mandibular complete denture are often problematic. The decreased retention and stability often lead to reduced function that makes conventional denture frustrating to the patients. The problem is accentuated more by the nature and rate of bone resorption of the mandible. Therefore, restoration of the edentulous mandible with implants supported over denture is considered the standard of care. For this treatment modality, the traditional two-stage implant placement with interim relining of the existing denture has been well documented. Although this method provides a stress-free healing period, the first several weeks after implant placement are uncomfortable for the patients, to the extent that functional limitation may continue during the entire implant integration period. To minimize this problem, immediate loading by different attachments was advocated. A recent systematic review and meta-analysis study by Schmel et al. In 2014 compared immediate and early loading to conventional loading of implants supported over dentures. The authors included only 11 studies that met the inclusion criteria for meta-analysis out of 3,142 identified articles. They found also another 47 prospective reports. The meta-analysis of the 11 studies revealed a statistical tendency to support conventional over immediate loading. Of the studies, the 47 one with lower evidence demonstrated partially contradictory findings. After 1 year, the tendency was to adapt a primary stability over 65 implant stability cotton or insertion torque over 35 Newton for reports with higher success rate. Therefore, it is wise to assume that any methods that would increase the primary stability will favor immediate loading. To satisfy these requirements, several authors tried to use bars to splint the implant. Bar can be supplied with clip attachment, stud attachment, or milled to provide retention through parallel surfaces. When bars are considered over 3 or more implants, they can be completely lock the movement of the denture, but at the same time, they can overload the implant if the implants are short or in linear configuration. When constructing bars over 2 implants, they have variable degrees of resiliency according to the cross-section of the bar used. If the bar cross-section is round, it is termed resilient bar design. If oval, it is termed semi-resilient, and if rectangular, it is termed rigid bar design. It is a matter of controversy. Which type of bar should be used? Or what are the best criteria by bar selection? Increasing implant primer stability and at the same time providing some form of stress breaking mechanism may be beneficial. The possible way to achieve both goals is to use a resilient bar attachment design. This is the view of the River Nile at the High Dam in Aswan in Egypt. The present study was conducted to evaluate the effect of 3-bar and clip attachment designs on the supporting structures around the implants in mandibular overdenture cases. The 3 tested designs were resilient, semi-resilient, and rigid bar and clip attachment. Study population and protocol. The criteria for patient selection, it could be cooperative patients, free from debilitating systemic disease, good oral hygiene habits, enough bone in the anterior mandible to support dental implant, non-smokers. All these criteria can be obtained according to the patient's history, dental and medical history, lab investigation, clinical examination, either extraoral or intraoral, visual or digital examination. Seeking new denture treatments. 30 patients were selected from the outpatient clinic of the Hospital of the Faculty of Dentistry, Minya University. 18 were male and 12 female. The mean age, 49 plus or minus 5.5 years, completely edentulous with class 1 angle relationship and U-shaped mandibles. 2 implants, 1 piece, were inserted at the canine region of 3.7 millimeter diameter and 13 millimeter length. Immediately loaded with 2 weeks by a bar, randomly allocated in 3 equal groups: rigid, semi-resilient, and resilient bar attachment groups. The study outline was approved by the Research Ethics Committee, Faculty of Dentistry, Minya University. The nature of the study was explained to each patient's limitation, benefits, and side effects. Each patient signed an informed consent. This is one of the selected case at diagnosis stage, showing inflammation as a result of the ill-fitting lower denture. As you see here in the lower ridge. All patients obtained a new denture constructed according to the standard technique. The lower denture, pre-surgery OBG with the previously constructed acrylic stent, ridge mapping to determine the bone width at the canine region. The radiographic acrylic stent was modified to be act as a surgical stent. Placement of the implant using crystal and releasing incision to reflect the flap. The bone shapes from the drill were collected and used to graft the buccal 2 to 3 millimeter threads of the implant when necessary. This is the implant in its place in the osteotomy. And as you see, this is the bony shapes collected to be added in the 2 to 3 millimeter around the neck of the implant. 30 Newton torque range were used to seat the implants in its osteotomy and then suturing. Castable bar abutment and fixation screw were selected according to the gingival thickness. Connection of the castable bar abutment during the second week post-implant placement. This is the 3 types of the bar used: resilience, semi-resilience, and rigid one. Adjustment of the bar length intraorally. Adaptation of the bar into channels created in the castable abutment. As you see, this is a channel. Fixation of the bar with the abutments by burn-out acrylic resin. Metal try-in of the casted bars to see there is enough space between the bar and the gingiva, at least 0.5 millimeter, and the passivity of the bar when put it on the implant. In case of incomplete passive fixation of the bar, it was a split. Then the bar was reassembled with complete passivity by burn-out acrylic resin. After that, fixation of the bar after polishing. Then positioning of the clip attachment over the bar. Blocking out of the space around the bar for clinical picking up. Only the clip was left for fixation to the denture base with monomer-free rebase material. Finally, the denture after clinical picking up of the clip attachments. The patient is recalled to come again for the clinical follow-up and check through the clinical and radiographic evaluation at 2 weeks, 6 and 12 months. Radiographic evaluation were done by using the Longo-Cone barreling technique and the Digora software. Clinical examination done through the gingival index, amount of clavicular fluid, periotest values, radiograph for the evaluation of the bone loss around the implant by the Digora software. Evaluation of the implant mobility by periotest. Collection of the clavicular fluid by the paper, and then evaluated the amounts of the clavicular fluid by weight. Patient satisfaction done through questionnaire. Each question was scored from 1 to 5. 1 is the weak, 5 is the strong, and evaluated by non-parametric testing. This is the sugar cane farms present in Luxor. My results show the radiographic evaluation. There is a bone loss around the implant showed significantly change with time from 6 months till 12 months. And also there is a significant change between the group. High value appear in the rigid bar, the moderate one in the semi-resilient, and the lowest value appear in the resilient bar. The change of the periotest value during the follow-up period for the right side implants were non-significant, either between the group or regarding the time. The same tendency of the periotest value around the left side of the implant. The change during all the follow-up period were non-significant, either between the groups or regarding the time. The dot line representing the rigid bar, while the red one representing the flexible one or resilient one, while this solid green line representing the semi-resilient one. For gingival index, the change of the gingiva during the follow-up period were also non-significant, either between the groups, in implant site, or regarding a time. The red line, again, is the resilient one. The solid blue line is the rigid. The dotted line is the semi-resilient. The same tendency for the clavicular fluids. Show non-significance between the groups, some significant values between the groups and regarding the time. For patient satisfaction, the scores of the different variables, either comfort, stability of the mandibular denture, stability of the maxillary denture, retention for both maxillary or mandibular, chewing ability, appearance, and speech, all these variables show non-significant difference either between the groups or regarding the time. All the score ranging between the score 3 or 2. Further follow-up was carried out for 5 years on biannual basis and included bone level change and patient satisfaction. The patient satisfaction scores increased slightly for the 3 groups during the whole period of follow-up with no statistical significance. The bone level change during the 2nd year of the follow-up were essentially the same for the 3 groups, around 0.1 millimeter, and remained unchanged for the whole follow-up period. This is another view in Aswan. This is the Platen Island. Under the limitation of the current study, it may be concluded that resilient bar design produced less bone resorption than the other 2 designs, which may be due to stress reduction over the implants. On the other studies parameters, the 3 designs have similar influence. Further studies are recommended to reveal if there will be adverse effects on the posterior residual ridge with different bar designs. This is the balloon trip in Luxor. I wish everyone here to come to do it, to see all the pharaonic temples from the top view. Thank you. Any question?
You're not on yet. This is the problem with dentistry and dental hygiene. Dental hygiene just doesn't get any respect.
That's not fair. From a dental hygiene perspective, two questions. What kind of oral hygiene aids do you show them to clean under the bar? And do you have your hygienist remove the bars every 6 months or 12 months?
This is a good question. For the hygiene, the bar, we learn as a patients how to do the hygiene for the bar, starting with dental floss under the bar and the small brushes, interdental brush to the corners. This bar is screwed, as you see. You can easily go to the dentist to remove it and clean it and do all and then screw it again for the apartments. Yes, yes, I recommend it to do every 6 months. It's much better. As some area it's near to the corners of the bar, the patients can do it enough.
Other questions? Yes. Just 1 second. We'll
Indonesia. I was curious about your research actually. It is safety when you just use this bar design. I mean, was there any complication or allergic syndrome when you just used the bar design?
Any complications
Yeah,
for
complication.
constructions?
Yeah, that's right. Mhm.
Yes. If we do any attachments treatments, we need both things, good doctors and good technician with you. You need to take everything, as I mentioned, there is some cases you need passivity, some cases we don't to do the passive. If we don't have the passivity means you put the bars and we go for the apartments. If this is not easy to do it, we can split it and reassemble it again, as I mentioned, and then resoldered, and we do it again. So you need good technicians and good dentists. You how to do that, or trained for that, and also good patients for the oral hygiene and to follow the instructions. Thank you.
Well, Professor, on behalf of you and your colleagues at the University of Manila, let me thank you for your very fine presentation and for the wonderful photos of Luxor and Aswan. They're wonderful places to visit as well. And so thank you very much. Won't you join me in thank you.
Ajinkya. Yeah. Next one. Yeah. This
one. Our next presentation will be Dr. Ajinka Pawar. On your schedule, Dr. Bamagja and his colleagues have been delayed and will be presenting at a later point in time in the conference, assuming that the airlines and air connections cooperate. We have a couple of people today who've not been able to join us due to adverse weather. So we'll move ahead one in the program and turn to Dr. Pawar, who's a professor of endodontics. Thank you and welcome.
So yeah, thank you very much for this wonderful introduction and welcoming me to the United States to give a presentation on some of my researches which I have been done with a new file which is used for root canal treatment. So once again, good afternoon one and all. I come from a country that is India where diversity is at par, and we always say namaste and we greet everyone by joining hands. So I'm saying namaste to one and all.
Namaste.
Here's one video which I would like to show you to give a gist of India, the country which I come from, is just for entertainment purpose and also just a funny way where a American Indian who has made a video to show what is India all about.
I'm Indian. Just Indian. I'm not South Asian any more than Russians are North Asian. I'm not Asian Indian or East Indian. There are 1.3 billion of us. We don't need a cardinal direction, okay? It's not our fault that Christopher Columbus got lost. Sure, we love our states, but there's strength in numbers. 1 out of every 6 human beings is Indian. So stop dividing us. The British already did that once. And we need to quit saying that we're not Indian because I wasn't born here or sound like this or eat that. Our hearts are Indian. We are feelers. We gave the world the romance of Bollywood films and the music of Ravi Shankar and Zubin Mehta and Lata Mangeshkar and Asha Bhosle and the allure of the Kama Sutra. We are thinkers. We are great at math because we invented numbers. And we're pretty good at letters, too. We are doctors and engineers and techies. And we mean business. We are the world's 3rd largest economy and the wealthiest ethnic group in America. We are huge and efficient. India is all on one time zone. That way everybody in the country is still late, but at the same time. We never invade anyone because we already have everything. Chess, the ruler, the button, wireless communication, arranged marriage, flush toilets, steel, democracy. All us, all India. And you are welcome, world, for yoga and elevating cricket into a multi-billion-dollar sport and making food so good that you sailed across the planet to come have some. Our food is hot. Our country is hot. Our women are hot. Our men are lucky. Where the world prays, we meditate. We practically invented religious tolerance, and we gave you Mahatma Gandhi and pundits and gurus and karma and dharma and kismet and reincarnation. The motherland is magical and mystical, and no matter who you are, you can find yourself here in incredible India. Jai Hind. I am Indian.
So yeah, thank you so much for listening to that. I come from D.Y. Patil Dental School. This is a university located in western part of India in the state of Maharashtra. And I'll be speaking about the self-adjusting file instrumentation, which is a new file which has been introduced for the root canal instrumentation. I'm Dr. Ajinkya Pawar. I'm an endodontist by profession, and I am an associate professor in the Department of Conservative Dentistry and Endodontics. So yeah, we all are happy with whatever treatment we are providing to our patients comfortably, and the patients are also comfortable with that. So that is our comfort zone. As it is written on the title of the slide, that is the comfort zone. You can see there are 2 bowls which are present. On the left hand side, there are many fishes which are present in the same bowl. That is their comfort zone. But you can also see there is one fish which takes a leap outside the comfort zone and fetches a place into another bowl where it is alone over there, and that depicts its uniqueness. So here I would like to request all of you all to keep your minds free of your comfort zone, see what I am presenting, what researches have been done, and then decide whether you want to take the leap outside your comfort zone or no. So the researches that I will be presenting today are the current technologies which are used for root canal instrumentation and a new technique or technology, that is the self-adjusting file. To start off with, we all know that the holy trinity of root canal treatments is gaining straight line access to all the root canals which are present in the tooth we are treating, shaping and cleaning all of them, and subsequent 3-dimensional obturation. Conventionally, we used hand files which were introduced for shaping these canals. Nevertheless, these hand files always had some inherent disadvantages, like they were time consuming, less flexible, there was more debris extrusion periapically, and we all know if there is extrusion of debris periapically, there is post-operative pain, inflammation, and delayed healing. Also, because of the rigidity of these files, there were many canals that were transported. Then there was introduction of rotary or nickel titanium rotary or reciprocating files. Now these files changed our concept of endodontic treatment from to contemporary endodontics. It proved as a great technology as it provided more This is another microcity study which was done by Frank Paquet, and you can see the complexities of the root canals which are exhibited by mandibular molars. Now, for an example, if we have a tooth with a root canal which is flat and oval, and we use a rotary or a reciprocating file, you can see how it shapes the root canal, leaving most of the root canal untouched or unaltered. So what does a rotary file do, or a reciprocating file does, is it imposes a circular bore on every canal with any cross section. With this, it cannot address to the three-dimensional shape of the root canal. Here you can see in the section of a CBCT section of a maxilla, you can see the canine which is oval shaped or flat oval shaped. You can see the first premolar with two canals which are tear shaped, and you can see the second premolar which is again single rooted with oval shaped canals. Also, for the mandibular scan, you can see most of the teeth are irregularly shaped and not circular. So if we use these files again for such canals, it leaves more of the area untouched. There was another study done by Professor Metzger. He is my co-researcher from Israel, and we have carried out many researches together, and he is one of the developers of the self-adjusting file. This study was done before the introduction of the self-adjusting file. They had taken distal roots of mandibular molars which had single root canals which were oval. You can see here in the pre-operative is the red one and the post-operative is the yellow one. 2 mm from the apex, you can see that the file has instrumented well and addressed to most of the canal. This is because there is one study which has been published by Wu et al. In Journal of Endodontics only, and they have said that most of the root canals in the apical third are usually circular, and the oval shape of the canal starts from 4 mm or 5 mm from the apex. So when they went to the 4 mm and 5 mm sections from the apex, you can see how the rotary file has created circular bore for this oval shaped canals, leaving most of the canal untouched. Another study was reported by Frank Paquet using microcity again. They use distal roots of mandibular molars again which show oval canals, and here they use pro-taper files with manufacturer's instructions. And you can see that this file, when used according to manufacturer's instruction, left around almost 80% of the root canals untouched. They continued this study using the same files in circumferential manner, but again the percentage was reduced, still leaving around almost 70% of the areas untouched. Then the reciprocating files were introduced. You can see here in the histological section, this was again reported in Journal of Endodontics, how a keyhole preparation has been made for an oval canal and the vital pulp tissues have been packed into the canal recesses. This led to the evolution of a new three-dimensional adaptive endodontics, and that is the self-adjusting file. You can see in the picture that the self-adjusting file is a hollow, elastic, compressible file and made up of nickel titanium lattice. Like all other files, it is available in 3 standard lengths, that is 21, 25 and 31 millimeters, and 2 diameters, that is 1.5 and 2 mm. This file is not rotary, this file is not reciprocating, it uses a transline in and out motion. You can see that there is a different type of RDT3 head which has to be connected to your endomotors, which you guys always use. That can be a XMart, XMart Plus, or Cavo. You just have to connect this handpiece head, and that will connect the rotary or reciprocating motion into vibratory motion. Now, as this file is hollow, it is to be used with continuous irrigation, so you are shaping and cleaning at the same time. This is the only file which provides continuous irrigation during shaping. So there was one study which I conducted on oval canals to see the centering ability of root canal, the oval root canals, which were instrumented by 3 different files using 3 different kinematic motion. One was a rotary, one was reciprocating, and the third one was self-adjusting file. You can see here that the rotary files could not or failed to reach the buccal and lingual recesses, and they did a good job mesiodistally. But the self-adjusting file, as it is compressible, it adapted to entire root canal shape. From the graphs also, these files in the middle third, coronal third, middle third, the other rotaries and reciprocating files could not reach the buccal and lingual recesses, whereas in the apical third there was no difference between the three groups. Now this is the only file which can adapt to the root canal shape. As you can see in these two X-rays, one is a mesiodistal, other is a buccolingual X-ray. On this side you can see that the file is compressed, and the other side the file is elongated because of compression on the other side. This is how it adapts to the root canal shape. You can see here by this video how the compressible file adapts to the root canal shape. Once you take the working length and you place it in a clear acrylic block, you can see how the file is getting compressed, thus adapting to the shape of the root canal. Now how much does this file can get compressed? You can see there are two X-rays. This is the 1.5 mm self-adjusting file, and this is a root canal which has been created, a glide path has been created till a 20 number K file. So this file can be compressed to a size of 20 number K file and can be elongated to 2.4 millimeters. That is how much ever elongated the canal is, it will get adapted to the root canal shape. Now for irregularly shaped root canals like this one, if it is a tear-shaped root canal, in order to include all root canal surfaces, you have to over-instrument the root canal. Again, the currently used rotary or reciprocating files have various tapers which are present, and still if you use larger number files, after obturation still there is some area which is remaining untouched, and also the remaining dentin wall thickness is very less. So when you use larger taper files and larger size files, there are always chances of micro cracks which are there. Kim et al. Recently published in Journal of Endodontics the amount of stress which is generated in the root canal by different rotary files, and he stated that the rotary files created almost 350 to 389 megapascal of force on the radicular dentin, whereas the dentin's tensile strength is 106 MPa. And then he continued this study with the self-adjusting file, and he found out that self-adjusting file created merely 10 MPa of force. You can see here by the video the stress that is generated by the self-adjusting file throughout the root canal. You can see the entire part of the root canal is in the green section, which is the most acceptable, and very few areas which are red. So when there are microcracks formation, we ran one study in collaboration with Tel Aviv University to see the microcracks formation using again wave 1, ProTaper and self-adjusting file. The rotary files created in the samples, 40% of the samples showed microcracks, whereas in reciprocating group, there were 30 samples which showed microcracks, whereas with the self-adjusting file, none of the samples showed microcracks. So when there are microcracks which are present, we do subsequent obturation to it. Even while obturating, if you are using any lateral condensation technique also, there are chances that these microcracks can propagate into fractures. So the the resistance to fracture of endodontically treated teeth are also reduced. So I recently published another article to see the fracture resistance which had been done when the samples were instrumented with 2 rotary files and 2 reciprocating files, and compared it to the self-adjusting file. The self-adjusting file fracture resistance, the samples of the self-adjusting file, the fracture resistance was similar to the control group, whereas those which were treated with rotary or reciprocating files, they were significantly less. Now there is something known as formation of debris when you are doing a root canal instrumentation. This is a video which will demonstrate how the debris have been formed and packed into the canal recesses when you are instrumenting root canals. You can see here that in the mesial roots of mandibular molars, there are canal isthmuses which are present, or communications which are present, and when you are instrumenting them, these debris get packed into the canal recesses or isthmuses. This was just by animation, but using a clear acrylic block also which shows some lateral canals which are present, they are actively getting packed by debris during instrumentation. So Frank Paquet again did one study using microcity to see the amount of debris which are packed or formed during root canal instrumentation into the mesial roots of mandibular molars. So they found that ProTaper caused 10%, whereas the SAF caused only 1.7% of the debris to be packed into the canal isthmuses. Now, when there are debris which are formed, they can either get packed into the canal recesses or isthmuses, or they can be extruded periapically. As I said earlier, when there is extrusion of debris periapically, there is 100% post-operative pain, post-operative inflammation, and delayed healing. So recently we published one article to see the extrusion of debris periapically by the self-adjusting file with continuous irrigation. And we found out that the reciprocating file resulted in maximum amount of debris extrusion periapically, followed by the rotary pro-taper next, and then the self-adjusting file, which was associated with continuous irrigation. Also, during retreatment, the self-adjusting file was the least which extruded the debris. Now, why there is less extrusion of debris is only because this file does not have any cutting flutes or blades, and it does not cut the dentine. It has an abrasive surface which abrades the dentine, resulting in creating of dentine dust, which can be easily removed by the continuous irrigation. Now, when it is associated with continuous irrigation also, there are chances what question might come about extrusion of hypochlorite during instrumentation. But this video, you can see that they have over-instrumented the root canal, trying to create a bigger apical foramen, and then they have used the self-adjusting file with continuous irrigation, and you can see that nothing has been extruded periapically, not hypochlorite also, nor the debris. But then when they use needle and syringe irrigation in the same tooth, you can see the extrusion, ready extrusion, which is taking place, where the irrigant is being pushed from the coronal axis. Also, the irrigant is coming out of the apical foramen. Now, when there are debris which are formed or packed into the canal recesses or isthmuses, there was one recent study which was published, and they use ultrasonic irrigation activation to see whether these debris can be removed or no. And these were the results. The debris cannot be removed even after ultrasonic irrigation activation. So when there are debris which are present into the canal isthmuses or irregularities, you cannot obtain a three-dimensional ideal obturation which is to be obtained. So DDS reported in Journal of Endodontics in 2012. You can see here that they had used paired oval canals. They instrumented one of the group with pro-tapers, again with copious irrigation with concentrated hypochlorite. And you can see they have used a carrier-based obturation, which is a thermoplastic obturation, and readily flows into the canal irregularities. But you can see here this area which has been packed by the debris, this obturation material could not flow into the irregularities. Now you can see with the self-adjusting file how the areas were cleaned, and thus the thermoplastic gutta percha could create an intimate contact with the radicular dentine. Now, when there is intimate contact of the root canal fillings to the radicular dentine, the push-out bond strength of the obturation also increases, and there is less chances of leakage. So, we recently published one article in International Endodontic Journal to see the push-out bond strength of root fillings, which are made after instrumenting oval canals by either self-adjusting file or by wave 1. We used two obturating materials. One was gutta percha with AH+, and the other was C-point and endosequence BC sealer. So this C-point is another obturating system which has been recently introduced. This is a hydrophilic obturating material which expands on absorbing the moisture from the radicular dentine and expanding and getting an intimate contact with the radicular dentine. Also, when we saw only for gutta percha group, those samples instrumented by SAF showed higher push-out bond strength in the coronal, middle, and apical third of all the samples when compared to the wave 1. Now, during retreatment also, recently article has been published that only using retreatment files alone cannot remove all the root canal fillings which are present into the radicular into root canals. So we recently finished this study of using self-adjusting file as a adjunct to remove root canal filling residues. After using the retreatment files, 26% of the root canal filling was still present inside the root canal, and after the self-adjusting file was used, this was reduced to 7%. To conclude, we cannot guarantee success, but we should spare no effort to deserve it. Thank you.
Thank you, Dr. Pawar. We have time for a number of questions. Questions from the audience.
Ajinkya's lecture is very interesting, and I have chaired one of his sessions at FAMDENT India, so I know. I have done my oral pathology with his mother, so it goes back a very long way in India. I've done my post-graduation with his mother, who's passed away many years ago. Ajinkya, just a simple question. In a country like India, how much clinical practice would you be able to do with this kind of system? How much would it cost you to treat a patient with this kind of system? Because you need to buy everything new. The whole thing is different from what we have been used to up to now.
Yeah.
So how does it work? I wouldn't talk about America or any other country, but how does it work in India?
See, the only problem, they have discontinued it in the United States only for one reason. Why? Because these people were not, none of them took any a course or any guidance from someone who's already using this file system. That is the reason in the United States it is discontinued, but they are starting it again. Again, when it goes back to India, madam, 100%, I to use this file because the only reason is the patient, the clientele which is present. It is not only that you should check for the availability of this file, but obviously the patients which are there who are willing to pay more, that is more important. And also, where it goes back, again, rubber dam application in India, it is also at par at now, present. Now everyone is using rubber dam for all root canal treatment, so that is also one. But when you are trying to use this file, it is 100% better that you take a course before using this file. Because we are used to using these rotary files which are solid metal core and we can push it. But if this file gets, you cannot force this file inside the root canal, otherwise it will get entangled, that's it.
Doctor, I have a question for you. You note with SAF the improved sanitation and disinfection.
Mm-hmm.
And you've been using that with sodium hypochlorite.
Yeah, you can use any irrigant.
Would you not have increased concentration and exposure to trihalomethanes as a result of using the sodium hypochlorite?
I don't get it. What did you say?
Would you not have an increased exposure of the patient to trihalomethanes resulting from the use of sodium hypochlorite as a result of the increased sanitation of the process? Trihalomethanes are common byproducts of the use of bleach, and bleach has been used historically in endodontics, exposing patients to potential carcinogens. I'm wondering whether this accelerates that exposure or not.
No, because this is again, the treatment has to be done with the proper isolation. The main important thing is that, but again with hypochlorite, we over there, we do not use concentrated hypochlorite, we use either 1% or 2.5% maximum, or else we use chlorhexidine.
Mm-hmm. Okay, thank you.
That's it.
Other questions? Then let me thank you and ask the group to thank you for your presentation. So So we have now reached an important juncture in this meeting called a coffee break. But before we break for coffee, we have a request that has been made for an additional group photo. There were a number of people who were not able to participate. So I would ask you ask your indulgence if you would all reassemble up here for a group photo, and then you can have the coffee break. Thank you. I might add, it's about 5 minutes after the hour. We'll have the group photo, 10-minute coffee break. We'll reassemble at 15 after the hour. So let's come up and have our pictures taken if we could. Yeah. You're going to be far more casual. I'm pleased to provide Faud Al-Omari, and he's with the King Khalid University School of Dentistry in the Kingdom of Saudi Arabia. We're just absolutely delighted you could make it. It's no fun being up in the air circling, wondering will I ever join this conference. So please welcome here, and we look very much forward to your presentation. Faud.
Thank you so much. Thank you. Thank you, sir, for the presentation. Thank you, everybody. Recently, Dr. Faud Al-Omari, recently I'm board resident maxillofacial surgery. This is our cases before get the acceptance for the board surgery board. Want to present this case is today suffering from the dystrophic epidermolysis bullosa. We want to define the condition first, epidermolysis bullosa, which is the inherited connective tissue disease that cause blisters in the skin and the mucosal membrane, resulting from that lead to due to the anchoring protein deficiency between the dermis and the epidermis layer under the frictional force and the minimal trauma. The layer of skin and the mucosal erupt off by the minor trauma and touch. This condition can be called butterfly children, cotton wall children, and in South America it can be called the crystal skin children. The incidence of the condition is about 1 in 17,000 live births worldwide. Normally in a healthy skin, we have a two-layer epidermis, which is the outermost layer, and the underneath is the dermis. Between them, there is a protein anchor called the protein anchor that bind the two layer to prevent the layer rubbed off under the shearing force. In people with the condition of epidermolysis bullosa, that protein is deficient, so under a minor trauma or a frictional force, the outermost layer is rubbed off. Suffers from this condition can be compared with the third degree of burn, and also have increased risk of skin malignancy. We have different types of the epidermolysis bullosa. We will not go deep pathologically, but want to mention each type. The first type is epidermolysis bullosa simplex, which is the condition where the blisters formed at the site of the trauma, minor trauma. Mostly it's occur in the feet and hands. The second type is the junctional epidermolysis bullosa, which is the disease that is affecting the laminin and the collagen that's found in the lamina lucida, which is in the basement membrane zone, epidermal zone. The third type, which is our condition here to present, the dystrophic epidermolysis bullosa. This condition is the deficiency, which is the deficiency in the fibril protein located below the basal lamina in the epidermal basement membrane zone. Signs and symptoms of the epidermolysis bullosa can be seen in the clinic are the blistering of the skin, tooth decay due to the inability to brush and make the good oral hygiene, deformed and the lack of fingers and toe nails, internal blistering in the throat, stomach, and intestine, scalp blistering and loss of hair, hardening of the skin of the feet and hand, difficulty in swallowing. Diagnosis based on the clinical finding and immunofluorescence and the electron microscope to differentiate each type of the epidermolysis bullosa. The treatment, little of papers mention that we can use the transplantation of the laminin 5 modified stem cells, or injecting the sulforaphan compound, which is the compound taken from the vegetables like broccoli, can be changed the mixture of the keratin in the skin to reduce the blistering formation, or inject the subcutaneous, the granulocyte colony stimulating factor that may promote the and increasing the wound healing. This is our two cases with the condition dystrophic epidermolysis bullosa, two siblings, two sisters, one with the 15 years and the next with the 14 years. They're suffering from the condition since birth. They came to our clinic with their mother complaining from the general oral pain and the inability and the difficulty in feeding since birth and developed with their years. The mother asking for the interested doctor to accept the case as for the full oral treatment as rehabilitation. Through the taking a history, medically the patients, both of them have iron deficiency anemia and low level of the multiple vitamins. They are under dermatologist care with the medications like antihistamine and the cream with the antibiotics due to the infections of the blisters. Through the dental history, the patient wants to short dental clinic visits and the simple temporary dental management. Their ankle have the same condition with epidermolysis bullosa. Socially, the patient doesn't want to school, no friends, no activities because prohibited from the touches and falling down. Psychologically, the patient's a little depressed. Generally, the patient has a general pain with the touching, fragile skin, multiple skin sores, blistering of the skin, especially scalp, hands, feet, loss of hair, hardening of the hand and feet skin with the deformity and the lack of fingers. It's called the mitten hand. Orally, the patient have limited mouth opening, source of the corner of the mouth, palate, tongue, and the buccal mucosa, microglossia and ankyloglossia, bad oral hygiene, multiple teeth decay with the remaining growth, fragile mucosa with the white patches, and the weak teeth with the alveolar bone. During investigation, blood work is taken with the electrolytes and the minerals, bone profile. It shows the iron deficiency anemia and also low level of the multivitamins. A skin biopsy and electronic microscope is taken and that confirm the type of the epidermolysis bullosa, which is the dystrophic. About our plan, this case cannot be managed under GA because the difficulty of the anesthesia during intubation. So the condition should be managed under local anesthesia. So we go systemically by the periodontal treatment, surgical, endodontic, and the aesthetic part restoration. The periodontal treatment is taken by the manual and the ultrasonic scaling. And after that, the surgical part is done. The extraction of the remaining growths, multiple remaining growths, and the posterior teeth that cannot be treated endodontically due to there is no accessibility to do the endo treatment, so planned for extraction. During surgery, we face difficulties due to and challenges due to the accessibility and the cooperation of the patient. We didn't use the high force elevation during surgery due to the weak alveolar bone. We preserve the alveolar bone. And after we use the lubricant and wet gauze during the extraction and the procedure to protect the mucosa from the tearing. After the surgery, we make the local hemostatic agent due to the axis bleeding, and also careful suturing the mucosa. We observed the case 15 minutes after the procedure due to the chance of the hemorrhage. These pictures after the endo treatment for the most anterior teeth. After that, the fiber post is done to complete the build-up of the crowns. This is the final result of the oral rehabilitation for the both cases. After the dismiss patients, we follow the patient and to give the fluoride application for both of them, and educate the parents to brush their teeth, and also to keep the good oral hygiene and the oral intake. And this is what we advise for this condition in the oral rehabilitation and dentistry concern. So thank you so much.
Thank you. We have a question at the back, Dr. Ferguson. Wait for the microphone. We'd like to have the mic because it is recorded, unless you don't want to be recorded.
No, I'm fine. A couple of
On the
questions.
record.
Okay. What were the ages of these children when they came to you?
15 and 14.
Okay, so there was a family history. You said on whose side? Maternal or fraternal? Whose side? You said, I think there was an uncle or
There's
something?
uncle, yeah, the same condition.
So which side of the family?
The mother side.
Thank you. Okay. So what was the first, when was the first dental visit for these children?
It's around 6 to 7 years old age, but there is no complete visits during that because the doctor who is take the case just do the primary management because the faces the difficulties there, limited mouth opening, difficulty to cooperate the patient, a lot of difficulties.
So the girls were first seen by someone in private practice, not at a facility like you're at, a hospital facility.
Sorry again?
The children were first seen by somebody in private practice, or was it in a health facility
No,
like
in the
you
primary health center. Primary health center seen first.
So what happened? Why didn't they come back?
No complete treatment is taken. So
Okay.
the same complaint, the same problem is still there.
Yeah.
So the patients came with a lot of dental problem.
Okay.
But also there is some care with the mucosa, the skin, something.
Sure.
No dentists need to be touch that area, so or know how to manage. Some of them advise to do it under GA, general anesthesia. But from our side, it's impossible to do that due to the intubation. During intubation, you will lacerate all the mucosa in the way.
Sure.
So should be under local anesthesia.
So how have they been doing since you've completed your care with their home care? How are they doing?
During our care, after that, the follow-up is about 4 to 5 months. After that, the first to second visit or meet, can be called. It's okay.
So the hygiene is being handled at home?
The hygiene is still
Yeah.
there because you know the first moment after the treatment is finished, I saw that in the child faces and the mother also. It's
Yes.
different, the feeling.
And what's interesting, after you did your surgery, did you have any post-operative problems with tissue response?
The hemorrhage and also the the mucosa is not in a normal situation. So during the suturing, there is a little difficulties, tearing, but we want to take in another way, simply, and no tightening for that.
Okay.
After that, it's going well.
Okay. Thank you.
Thank you. Thank you.
Absolutely fascinating cases. other questions that people would like to pose? Well, then let's join again in thanking Faoud to stay up umpteen hours on an
Thanks so
airplane
much.
and then
Thank you.
arrive
Thanks so much. Thank
and
you.
tell us. So,
Thanks so much.
very
Thank you.
Let me offer this as well. Sure. Thanks for the presentation. Very good. Thank you. Okay.
Can I get it?
Okay, so I'd like to put this one.
We'd now like to welcome Dr. Ali Agami. I need my glasses. He is a member of the Oral and Maxillary Surgery Department at King Fahd Hospital, Baha Kingdom of Saudi Arabia. He won second prize of Best Research in IRAM 2014, King Saud University, Riyadh. He is the organizing committee member of the first Saudi Maxillofacial Surgery Conference in Jihad KSA and Riyadh 25th International Dental Conference. Let's welcome him.
Thank you very much. Today I'm going to talk about the influence of dimensions on the primary stability and removal torque of short dental implants. Just as an introduction, successful osseointegration has an important influence on the long-term success of dental implant restorations. While primary implant stability and osseointegration can be predictably achieved in dense bone, it's often challenging to achieve the same in areas with poor bone quality. Studies have demonstrated that initial implant stability is influenced by factors such as the length and diameter of the implant design, the micromorphology of the implant surface, the insertion technique, and the congruity between the implant and the surrounding bone. Low-density bone implant sites have been pointed out as the greatest potential risk factor for implant loss when working with standard bone drilling protocols. Clinical study with consecutively placed implants that were immediately loaded showed a higher failure rate in low-density bone, reinforcing that the primary stability is a major determinant in the success of immediately loaded implants. Among these, resonance frequency analysis has been revealed and widely used as the most successful method to assess primary stability because of its easiness, accuracy, and non-invasiveness. The implant-bone interface is measured based by resonance frequency, which is the reaction to oscillation exerted to the implant and is expressed as implant stability quotient. On the other hand, mechanical tests such as insertion, torque, and value of push-out test showed positive correlation to the primary stability. Hence, non-invasive measurement methods have also been introduced for the diagnosis and prediction of immediate and the long-term implant stability. Studies have shown that the measurement of removal torque strength was a useful indirect biomechanical method to evaluate the bone and implant interface. This preclinical trial done to compare the evaluate the primary stability and removal torque measurements of short dental implants in different dimensions. Materials and methods: fresh 6 years bovine ribs from middle part of the rib, procured from the pusher shop were used for the study. They were cut into 6 centimeter long pieces and 1 centimeter thickness, and total of 20 Bouveret blocks were prepared. The cortical bone was removed until it was about 1 millimeter thick in order to make it mimic to type 2 bone. 20 T5 implants manufactured by Nucleus have used in the experiment. We classify it into 2 sets. First one, 10 short implants with a diameter of 4.8 millimeter with 2 different lengths, 5 and 7 millimeter, were used to assess the resonance frequency and removal torque value. The second set is 10 short implants with a diameter 6.2 with 2 different lengths, 5 and 7 millimeter, which were used for comparison. After installation, the ISQ was measured by using of a resonance frequency analyzer. The osteotomy sites were prepared according to the manufacturer guidelines. After implant insertion, the magnetic wireless RF analyzer was used for direct measurement of the endosteus implant stability. The RF analyzer technique analyzes the RF range 110 to 10,000 hertz of SmartBig, which can be attached to the implant. The probe of a wireless RF analyzer was held perpendicular to the implant as indicated by the manufacturer. The RTV of each implant was measured using a digital torque MGT50 digital torque gauge instrument. The peak force measured at implant loosening was scored as the torque out value. We used analysis of variance ANOVA. P-value less than 0.05 were assumed to be statistically significant. Going to the results, the mean values and standard deviations of resonance frequency measurements are shown in this table. If you want to take a look, and I will go to the next slide. Implants showed ISQ values of 45.08 plus or minus 2.29 and 46.45 plus or minus 1.6 respectively for 5 and 7 millimeter. For the 6.2 millimeter implants, the ISQ values were 50.5 plus or minus 1.05 and 51.57 plus or minus 2.06 respectively for 5 and 7 millimeters implants. We can see also the same results in this figure. Even though the values were higher for 7 millimeters in both groups, it was not significant. However, when it showed significant difference, p-values less than 0.01 between the 4.8 millimeters and 6.2 millimeters diameter implants at both dimensions. The mean values and standard deviations of the removal torque measurements are shown in this table too. The removal torque measurements showed no significant differences between 4.8 and 6.2 millimeter implants with 5 and 7 millimeter lengths. The removal torque values show significant difference with the different diameter of the implants used. The 6.2 millimeter implants showed significantly higher removal torque value compared to the 4.8 millimeter implants. Several critical factors are necessary for successful osseointegration of dental implants, including the primary stability and surface characteristics of the implant anatomical conditions. The primary stability of the implant, which results from the initial interlocking between alveolar bone and the body of the implant, affects the secondary stability of the implant because the later results from subsequent contact, osteogenesis, and bone remodeling. The stability of implants can be successfully assessed by the OSCEL device, which quantifies the RF. Resonance frequency is a non-invasive objective method to evaluate implant stability, and it has been validated through in vitro and in vivo studies. The technique is based on the measurement of the RF of a small piezoelectric transducer attached to an implant or abutment. The primary determinants of the primary stability of an implant are the surgical technique used, the design of the implant, and the mechanical properties of the bone tissue. The removal torque is defined as the amount of torque required to unscrew an implant from bone, and is determined by the total degree of contact between the implant surface and bone. The greater removal torque values may be interpreted as the higher stability of the implants. Bovine rib was used in this study and is classified as type 2 bone in other studies since contains thick, compact bone and dense trabecular bone. Going to the conclusion, from the observed primary stability, it can be concluded that short implants were able to achieve desired primary stability and in areas with good bone quality. The use of small diameter implants can prevent the need for bone reconstruction like bone grafting or other augmentation procedures. Thank you very much. These are the references. Thank you.
Thank you. Question, yes, and if you'd wait for our colleague to bring the recording device.
Thank you, Doctor, for this nice presentation, but I have some questions, and I need your patience with me a little bit.
Go ahead.
Your study was aiming to study the implant stability. At which area? Intraoral, extraoral?
Actually, the aim is to study the primary stability, to compare it with the different dimensions. So the area, it's not the concern of the study.
Actually, if you are going to use 6 millimeter lens or 5 millimeter lens, you are going to use such lengths for craniofacial implants, not intraoral implants. And that's why the area is very important, because each area will have some functional demands different than the other. This is one thing. The other thing is, you stated that you are comparing type 2 bone. And type 2 bone is actually in the anterior segment, just parasymphysial of the mandible. You may find it in anterior part of the maxilla. But in areas where you are phased to insert smaller implants or shorter implants, such as the posterior maxilla or the posterior mandible, you will find either type 3 bone or type 4 bone. That's why I asked you first for which area you meant to do your study. You have done a very nice work, indeed. But I think you should have addressed this situation first.
Yeah, I can understand your concerns, but I want to just clarify that the study is just focusing to that we can get a primary stability, a good primary stability. So
yes,
we can use this kind of implant. So we will not be forced to go for bone augmentation or sometimes in like
you have referred
sinus lifting in some areas.
You have referred first that shorter implants in poor quality bone have faced with a lot of failures, and indeed this is true. But we don't go to bone augmentation. We have some other techniques similar to bone condensation. For example, you use osteotomies, you use ridge wideners, you use any other techniques similar than this. The importance of your study is that you are using in vitro model to compare specifically 2 diameters and 2 lengths specifically.
Yeah.
And this leads me to my next question. Why did you use the ANOVA testing for this type of results? only because you have 4 groups.
So, are you suggesting another
Student t-test to test both
Two groups.
diameters first, and then both lenses, and between the groups. Student t-test will give you much more valid results because such results are not meant for ANOVA. And this is my humble remark. I'm sorry, I may be wrong, but this is my own experience that ANOVA is for multifactorial testing, for
Right.
several groups and longitudinal follow-up of the groups, of the different time intervals, covariables, and something like this, but not just binary systems of data. It will go better with the student t-test. Thank you for your patience.
Thank you very much.
And I hope we can see each other more and more often. Okay?
I hope too. Thank you.
I hope too.
Yes.
Thank you.
Thank you for your questions and your comments. Do we have other questions or comments from the audience, from the delegates? Well, Professor Al-Ghamadi, thank you very much for your presentation.
Thank you.
Is Hossam Amali present in the hall? We fear that he's been delayed in his transportation here. So I would like now to invite Al-Karni from King Khalid University in Saudi Arabia, in the Kingdom of Saudi Arabia, to kindly join us at the podium. Al-Khani, our next presenter, completed his board certification and special certificate in advanced restorative dentistry in Riyadh, Kingdom of Saudi Arabia. And he completed his master's in clinical and restorative and aesthetic dentistry at the University of Pacific in California, College of Physicians and Surgeons. He's currently working as assistant professor and vice dean at the College of Dentistry at King Khalid University. And he also is looking after a private clinic in his spare time. Welcome.
Thank you.
Thank you, Mohammed.
Okay, that's fine. Okay, good afternoon, everybody, or good evening. I don't know about the time now. Anyhow, I would like to welcome all of you to my presentation today regarding dental fluorosis prevention and treatment modalities. public health in the 20th century concurs with is important for optimum oral health at all ages. It's made available to service by two general means, systemic and topical. And for a better understanding to the tooth color change according to the dental fluorosis, multiple epidemiological studies were being done, and the U.S. Public Health Service sponsored by 1930s and a study by multiple studies by Dr. Den, and conclude that the fluoride optimum water level for case prevention average 1 part per million, and the dental fluorosis is associated with level more than 2 part per million. And the first U.S. communities were fluoridated in 1945. The absorption of the fluoride in our bodies came through two main ways, through the gastrointestinal tract and the bloodstream, and the distribution by plasma to all tissues and organs. Approximately 99 of the fluoride in our body located in mineralized tissue and in the type of the fluorapatite. The excretion of the fluoride go through the kidney and through the Sweet glands. The teeth can acquire the fluoride during 3 periods: pre-eruptive, mineralized stage, and maturation stage, and post-eruptive. The tooth surface fluoride, the fluoride in the enamel is the highest here on the external surface, and it will be little when you are going inside. And for the enamel, it's much richer by fluoride due to the rapid absorption. And by the cementum, it's also high once we have exposed cementum in case of the recession and attachment loss. The beneficial effects of the fluoride, as you know, mainly it's prevent demoralization by formation of calcium fluoride. And this formation will gonna enhance the remineralization of incipient caries once we have a drop in the oral mouth pH. So the fluoride will take care about this. It's gonna remineralize the demineralized tissue. And this equation to be kept with good oral hygiene and with fluoridated mouth rinse and toothpaste. Also, the fluoride is an enzyme inhibitor and can have a significant effect on the plaque metabolism. The unwanted effects of the fluoride therapy on the skeletal systemically, it's gonna cause the skeletal fluorosis. And this is concentrated mainly in the long bones. On the teeth, the excessive fluoride more than 2 parts per million will gonna cause dental fluorosis. And this is a result of the following actions: the excessive secretion of proteins or differences in their amino acid composition, inhibition of the photolysis of phenol proteins, amyloidogenesis, which term would prevent normal mineralization. Regarding the fluoride and the cancer, extensively were being studied, and up to now, this relation was not justified. For the overdose, we are following the WHO guidelines. As you know, the lethal dose of sodium fluoride is 5 milligrams per kilogram among the body weight. So will not prescribe fluoride until it's indicated. We're gonna decrease the amount of the traditional 2 milli of sodium fluoride mouth rinse to be used for preschool children to be half of the dose by 5 to 7 milli. And treatment of fluoride overdose in severe cases will be gastric lavage, and in severe cases, IV infusion of 10% calcium dulcinate to balance the fluoride inside the body. The benefits of fluoridation in the permanent caries, we are talking about the studies right now. It's when being fewer caries, lesion by 40 to 65%, root caries the same, almost 50% less. And for the primary teeth, the same issue will be reduced to 50% in the primary teeth. And for the periodontal status, it will be improved by improved bone density, and indirectly by lack of retentive areas of bacterial plaque. The prevalence of dental fluorosis, is this endemic or not? So it's a big question. Here in US, the prevalence of dental fluorosis, according to the American Academy of Pediatric Dentistry, it's almost up to 32% in 2002. And this can be attributed to increased availability of foods, beverage, toothpaste, and other oral care products and supplements. The group age, the highest prevalence was with the group age from 12 to 15-year-olds. And according to the CDC, the 23% of persons aged 6 to 49 had dental fluorosis. So the most of the fluorosis here in the US, according to the current data, is mild and barely developed by dental health, by non-dental health professionals. In my country, Saudi Arabia, we concluded that the fluorosis is present among 24.6% of the population. And this is mainly because of the rural areas are dependent on isolated well water. And our level were being found, I mean the stage of the fluorosis in the questionable and very mild categories. And these bring a lot of questions, by the way. So we started our own new national study, where being sponsored by King Khalid University, Saudi Arabia. We are starting to recheck this again, since we have the risk factor is very high, by the way. For better understanding for the fluorosis stage and treatment modalities, the dental fluorosis indexes were being established. The historical one and the father of that is the Dean classification, which being used for multiple epidemiological studies. It's very simple, by the way, but the Thiel-Strab and Fidgeri-Skoff index is the more diagnostic, more sensitive. It's going through the histological analysis and give good treatment outcomes. The TOS service index of fluorosis were being established for easing the diagnosis for the case once the fluorosis is the prevalent. And also the fluorosis risk index and modified development defects of enamel index were being also formulated to, again, to ease in the diagnostic procedures. And now, 2014, a lot of starting from 2012, but actually to find another way to better understanding of the fluorosis and better diagnosis, not to miss anything, by using the visual analog and also the quantitative fluorescence, and also for using the normal white light. So all of these is come with each other just to compensate the shortage in the diagnostic terminology and the diagnostic matters for the dental fluorosis. So please, I'm warning myself first that we have to go through the diagnosis of the fluorosis by systematic approach, not to miss any other, diseases other than the fluorosis. The management of dental fluorosis, it will be in preventive measure, first line, and then the therapeutic measures. The preventive measures by defluoridation, by avoid excessive fluoride intake during the late secretory and maturation phase of enamel. It's between 3 to 4 age, 3 to 4 years of age for permanent anterior teeth. And the upper limit, according to WHO, the fluoride is supposed to be at or less than 1.5 parts per million. The controlled use of fluoride in preventive dentistry, here we are saying again, we have to look to the indication and contraindication before starting any supplements. Supervision fluoride toothpaste used in children by supervising the toothbrushing, and related to the age and the weight of the children, and also the maneuvers of spitting out the paste after finishing the toothbrushing. The therapeutic measures, we are starting with the minimally invasive procedures as much as we can. So we're going to start with the bleaching. The bleaching is indicated in very mild fluorosis, according to any type of index. So the best result will going to come with combined in-office and at-home bleaching. This is case by Dr. Cloud, 2009. This is classical theta C2, and we can see here it's now B1. So this is very effective. This is one of my cases. I used the double technique in office and at-home bleaching, and it's promising. After that, if this is not working, we're going to go for microabrasion. The microabrasion, now it's more promising because of the new material like Prima and like the Blaster. This is for the mild fluorosis to some moderate fluorosis. And this is where being done by Dr. Howard, 2006. But what he did here, he used macroabrasion. We are trying our best to avoid macroabrasion due to the sensitivity, and also the end result will not be that promising. I mean the roughness and these things. So we have to go. For example, here sometimes we need it to open the access for the microabrasion, and sometimes using microabrasion alone. This is a blaster material. And after that, sometimes we are using bleaching, even after that, if the sensitivity scale is not that much. This is not working. We have to cover the labial and mask the labial surface, and this is for moderate fluorosis, either by composite or by ceramic veneer. So this case were being done by Dr. Shiraz 2014, and he masked all the area by composite, but according to Akbata 2014, with critical review on this, the composite is not that promising as porcelain laminate veneer, and it's going to cause a lot of irritation. Otherwise, also the bonding itself, we're going to have, it's not been studied well up to now. This is one of my cases, the patient with fluorosis, but the patient's chief complaint is just to close the spaces. So I close the spaces. I use the microfill. This is microfilled composite, and also I used hybrid composite in some areas, and it's not that promising, by the way. This is my case, but I know this is not the absolute or the excellent job for this patient. We are trying to keep and follow up. We're going to see if we're going to replace or not. And this is done 6 years recall case, were being done by Dr. Al-Jazairi 2001. This is very promising, and you can see this is after 6 years, by the way, by laminate veneer, porcelain laminate veneer. The full coverage is the last choice. We use this one when more than 50% of the labial enamel has been lost, or we have a severe fluorosis, or the other treatment modalities doesn't work. So we have to go in this choice. This is one of my cases. The bite and pitted and mottled teeth were be referred to my colleague orthodontist, Dr. Sommer. He did the job for the orthodontic treatment, and this is after orthodontic treatment, and this is my wax up for the patients, and this is my temporary for the patients, and this is my final crowns, and this is ceramometer restorations due to the socioeconomic of the status of the patients. So we did this, and this is the occlusal splint, and this is the lateral and left side. And also we have not to miss this issue regarding the aging time for fluorous teeth. It's now well known that's the double time, the normal time, and a lot of study now also talking about specific time. The bonding to fluorous enamel and dentin, so the best thing and the best technique is total edge technique to use here. It's more promising than the other techniques. Thank you very much, and any question?
Questions for Dr.
Thank you.
Alcorn?
Thank you, Doctor. I don't know if you're aware this week that the Health Department and Human Services and CDC have both recommended that fluoride levels in America be reduced by 30% in the water, down to 0.7, and they've defined that 40% of Americans are over fluoridated and have fluoridosis, besides the other possible medical dangers of fluoride. To me, fluoride is actually one of the greatest epidemiological disasters we've ever perpetrated in this country, and when we could do the same benefit from a topical agent from brushing teeth, and we will see what happens over time. But thank you.
You're absolutely right. It's a big concern, regarding the dental fluorosis, because we are trying to help the people, and again, aside, we are harming the people, and this is a logic to be seen, to be said like that. But actually, I think in US, and you are the one can talk better than me on this. They are keeping reporting and keeping following this issue. I mean, they never stop for this to keep to measure the level of the fluoride in the drinking water, either in bottled water or whatever. So we hope so that from our countries just to follow the same process for better prevention for dental caries.
Doctor, if I may. 2 questions from your very interesting presentation.
Thank you.
The first is, in the U.S., my understanding is the use of fluoride toothpaste, sodium fluoride toothpaste, 1,000 parts per million, FDA monograph, results in about a 10% ingestion of fluoride. I'm wondering whether the practices in the kingdom are comparable in terms of, you mentioned children's usage of fluoride.
Yes, sure.
The second question is a related one. We have a board member on my company who's from Fresno, California, which has well water, hundreds of wells. And so they never had fluoridated water because the logistics of fluoridating wells. You mentioned, and maybe I misunderstood, well water in the kingdom
Yes.
as being either a source of increased or decreased
No,
fluoride.
increase the fluoride.
Okay, could you elaborate a little bit?
Yeah. There is a study. There are a lot of studies were being done for this. One of it's for Prophet Shamari in 1997. Okay, and what they found, for example, in high region, southern region of Saudi Arabia Kingdom. Okay, they reached up to 3.4 parts per million, and this is so high. This is so high. So the matter of the supervising this is very difficult. So they're trying their best right now, the governmental, okay, to go through the fluoridation drinking water. Fluoridation of the drinking water is the solution for now. Stop the well water until everything is fixed. So this is the protocol right now, but still we have shortage also in the study of the epidemiological studies regarding the actual level of the dental fluorosis, since the risk factors is very high, are very high there. So we still in process in this. We are doing hard for this. The national support is there. The sponsoring is there. And I hope that after 10 years, I'm going to stand some places like this place and saying what we have right now.
Thank you.
Thank you very much.
In the matter of the children and the ingestion, is there a difference in practice of ingesting toothpaste amongst children in Saudi Arabia, or would the ingestion rate be roughly comparable?
Actually, up to now, we heard something like this, but nothing reported regarding the poisoning from the fluoride due to the injection, for example, from the toothpaste. So we have a shortage even in the awareness of this problem, and this is something public at the level of the public. We have this problem. So by this research and the coming recommendations, we're going to support and explore what we have in reality.
Okay, thank you.
Thank you. You're welcome.
Other questions? Most interesting presentation. Other questions? Well, if I could indulge one other then.
Thank you.
The Saudi Food and Drug Administration, which regulates the fluoride toothpaste, has had standards for years that have been comparable to the U.S. FDA monograph on fluoride. Do you see that changing?
Yes, sure. We hope so.
Yeah.
Thank you very much, Doctor.
Yeah.
Thank you.
Okay, very good. Please join me again in thanking Doctor for his fine presentation.
Our last speaker for today is Dr. John Nason. He has completed his MDS in the field of oral and maxillofacial surgery from SRU, Chennai, India. He is also the director for the Center of Technology Assisted Reconstruction Surgery, a 3D and printing unit with the core focus on healthcare. He is also a member of the Association of Oral and Maxillofacial Surgeons of India and the International Congress of Oral Implantology. Welcome.
Thank you, ma'am. I know it's not going to be easy being the last speaker, so I'll try to finish as fast as possible. Good evening, ladies and gentlemen. My name is Dr. John Nason, and I'm the director for STARS, the Center for Technology Assisted Reconstructive Surgery. The topic for today is use of 3D technology to design patient-specific implants in mandibular reconstructions. Mandibular resections, there are different reasons for which mandible can be resected. We all know that tumors, benign, malignant, you have osteolytic lesions, you can resect the mandible. Trauma can be one of the big reasons, and congenital defects. Now, when you resect a mandible, there are a lot of things that can happen. You lose form, you lose function, and we also lose aesthetics, because it's not just the bony part that you lose. You also lose a lot of soft tissue, you lose muscle, and you also can lose a lot of nerves over there. So these are a few shots of the resections. So reconstructing the mandible becomes very essential, because it helps to restore a person's function, form, and aesthetics. Different techniques of reconstruction have been there in history, and the most common until today, the gold standard for mandibular reconstruction is the free fibula graft. A lot has been done, I mean, ever since Dr. Taylor and Watson did it in 1978 till today. We are modifying free fibula grafts. There are different techniques that that happened. Hidalgo did it for the mandible in 1989, and then Young et al. Did for the forearm free skin grafts, and then you have scapular grafts by Schwartz. And okay, these all meant taking parts from other parts of the body for reconstruction, and that also created a lot of issues. So Kloch and Brennan, what they did is they did a mandibular reconstruction with an AO plate, and so on and so forth. Now this is a single reconstruction plate. You have double reconstruction plates. These are all, I'm just giving you a short history before I go on to technology, okay? Titanium meshes with iliac bone grafts are also there. This is a table by Lin et al. He gives a basic table which talks about the different grafts that were free grafts that are available, and each has its own pluses and minuses. But technology today is changing them all. The reason why people, when you take a free fibula graft or you take a scapular graft, there are two things that are involved. One is you take, not only have you resected the tumor as such, but you also are doing another surgery from another part of the body and taking it back and putting it, trying to replace it. So there is a second surgery involved. The patient, most of the time when you do a free fibula graft, goes home and is with a tube or is in the ICU for a few days, and he or she has to have their dental rehabilitation done only after 3 or 6 months. Today with technology, that is being shortened down. Today you can have implants being placed in the fibula also, but that's with technology. So there is a lot of discomfort that goes on in a patient when they do a mandibular resection. With technology, we are trying to see how this can be minimized, okay? So welcome to a world of 3D printing. What is 3D printing? 3D printing is always called as additive manufacturing. It's basically a process of making three-dimensional solid objects from a digital file. So what does this 3D printing got to do with healthcare? Let's imagine we take a printout, okay? In a 2D, you just take a printout, you have a paper coming out. If this was done layer on layer on layer, that is 3D printing. So today with 3D printing, it is crossing over across all borders: healthcare, defense, food, agriculture, architecture, games, entertainment, you name it, 3D printing is there. A small history, it started with Charles Hull in 1984. The first 3D printer was done in 1992. Today, you're even going up to creating 3D printing soft tissues. Okay, we'll talk about that a little later. The miniature human kidney model was done in 2000. In 2009, you had the first usable prosthetic limb. 2015, yes, in India, they did a 3D printed mandible, and by the grace of God, we were one of the few lucky guys who were able to design it and print it. So, different applications in healthcare. We have orthopedics, cardiothoracic surgery, neurosurgery, maxillofacial, plastic. There's a whole list of medical specialties that 3D printing is today crossing over. With more applications, more departments are being covered. We are going to talk more about the maxillofacial region, and in specific more about the mandible. So what is aiding this technological revolution in healthcare? One is the advent of volumetric medical imaging, the CT scans or the MRIs. There were days when we would go to a doctor, the first thing that the doctor would do was examine you, and then would come the x-rays. Today you go to any corporate hospital, the first thing they do is they take an x-ray or a scan, then they want to examine you. That's the way the whole trend is changing now. So CT scans are becoming more and more important. Now with CT scans, they're becoming more and more thinner. The slices are becoming, right from 2 years ago, they were about 3 mm slices, 1 mm. Today you're going to about 0.5 mm slices. So the more thinner the slices are, the more accurate your imaging trend is. The advent of additive manufacturing. Like I said, this is layer on layer. You add layer on layer to manufacture. So with additive manufacturing, we can make models, you can make customized implants from metals, non-metals, titanium, gold, anything that you name it can be done. So this is also helping in the healthcare revolution. The widespread use of virtual surgery. Imagine going into a theater well prepared even before you actually see the see the patient. This is today a reality. Today we have virtual surgeries, we have it in our center and in most centers in the US, I know it's there. So a doctor or a surgeon goes into the theater before even he actually sees the patient. You can actually prepare well in advance what the location is, where the tumor is, what are the connecting nerves, connecting vessels, where you want to do your resection, and if you're going to do a resection, what could be the probable reconstruction that you're going to do, planned well before you even actually touch the patient. These are the revolutionary things that are making technology used better. And last, the advent of biocompatible materials. Today, titanium is still the gold standard, but when you took off cranial implants, you have a material called PEEK, which can be used also, which is also used. Lastly, the future is bioprinting. Bioprinting of human cells, this was fantasy. Today, it is reality. In 2020, you're going to have, hopefully with 3D printing technology, we're going to be able to print human organs. It's already started in Lake Forest Institute in the US and Cornell University, where they have started to print ears. The ear and the kidneys have also been started. So in another 5 to 10 years, you're going to have different parts of the organs also being printed. Okay, in oral maxillofacial surgical, there are basically 3 things that they can do when we use technology. One would be mainly for diagnosis. When we talk of diagnosis, you talk of, all the while we had a CT scan, you had X-ray scans. Now imagine you had something that you can touch and feel in your hand for diagnosis. That is how much technology can go forward to. When you have your models, you can also do your virtual surgeries like I already mentioned, so your planning is much, much better. You look at every angle, you cover everything even before you go in for surgery. And lastly, whatever is resected, you can design that part which is resected by means of a customized implant. When I talk of planning, the first one that I saw diagnosis was models. Models not just for you, for the doctor, but also for you to explain it to your patients. You can show them, it makes it much easier to convince them that there is a defect and this surgery needs to be done. Virtual surgeries and customized implants. Just a few models. There are a lot of articles. You can name it, XYZ articles are there. One of the main articles is stereotherapy model technology applied in tumor resection in 2005 by Cunningham. And models can also be done to bend plates, specifically when you talk of mandibular resection. Today, not always can we use customized plates, so sometimes you can have your regular AO reconstruction plate. So when you have a model, an anatomic model of the defect, which is a 1:1 ratio, you can actually pre-bend the plate to the exact size, not just go to the theater and then meddle with it and you're wasting precious time. So when you pre-bend it even before you touch the theater, so the plate that you're going to fix for the mandible is already bent to the exact shape and exact size. So all that you have to do is open up, fix the plate, screw it, and out you go, which means lesser surgical time. The patient is out of the theater faster. It saves the patient money, and you go home early. Designing and fabrication of custom-made mandibular titanium trays. These are polyamide materials. With this, you can you can have a prototype of the design that you want to place in, and also these help like a scaffold, so where you can have cell growth being done. So once cell growth is there, then after a few months, you can just take the scaffold out, and then you are fit to place an implant in the mandibular region. Virtual planning. Today with good softwares, medical softwares, I mean, we use materialized softwares. So with these softwares, what you can do is, even the fibulas, still fibulas being used. So even if you want to do a fibula graft, how much of fibula graft are you going to take? Where are you going to cut? All these can be planned so that you don't have to cut the whole fibula for you to take a reconstruction. So this, based on the virtual planning, there are a lot of articles. Again, the article in 2015, and this is the latest one in Journal of Craniomaxillary Surgery, where you can read about the accuracy of fibula reconstruction using CAD/CAM implants. And this is in virtually also we can plan how we are going to reconstruct and bend a plate. Pre-shaped mandibular reconstruction plates are also available today based on the defects that you have. This is the new trend that's coming in now, trays which can take in grafts. So earlier we had reconstruction plates alone. Today you have mandibular reconstruction plates with a customized reconstruction tray. So if you still surgeons are still very comfortable with the grafting, so you can take in bone grafts from the iliac region that you want to push the grafts up mixed with allografts and autografts, so that you all have the grafts placed along the tray. And after 3 to 6 months, you can take the tray out, and then you are fit to place in implants. My talk more is going to be on patient-specific implants. This is what we do. This is the first actually patient-specific implant which was done in Netherlands. This was the design done fully made on titanium. This was the design. This was done for an 80-year-old lady who had tumor. They had resected the entire mandible and was reconstructed in one go. This is the customized reconstruction plate which we did at STARS in India. This is a patient whose history also is following, so I'll show you about that. What is unique about our design here is we thought, okay, the earlier design you had the plate as such, but then placing the dental component on top, that is the ultimate aim, took about 2 to 3 months. So we said, okay, why wait till that? Anyway, you're placing a reconstruction plate, so why don't we design that on day one itself? So what we did, we designed the dental processes also much before we actually went in for surgery. And so that's why we had the studs, the plate was also, the processes was also ready even before we went for surgery. So this is the design. These are the studs that we can make. This is going for patency right now. So this is what we did. This is another customized mandibular reconstruction plate where you have a trough. So this helps in formation of bone. So it's more stable. There is no rocking. This is not what we did. This was what I picked up from the net. This is the first design that you saw was without the condyle. So we said, okay, can we do it with the condyle? So this is one other design that we had where we also designed it with the condyle. And here we didn't need the dental component. So the patient was saying, doctor, I don't want the teeth as such. Just get me the mandible alone done. So this was the design that we did without the dental component, which is much easier. This is a design which is currently in process for us, and I'll just show you one more angle of this. So in the design itself, what we do is, see, these are the implant holes that we have given. So, and these are in the virtual surgery, what we plan is we place the implant to the correct angle in occlusion to the patient. You see how much length that you want. So we remove it, close it, primary closure is achieved. So you let the patient go home the next day itself. Luckily, the operation that we did, it just took us, normally when you do a mandibular reconstruction, it takes you about 6 hours to 7 hours with the fibula. We did it in 2.5 hours. And the patient went home, no ICU, no NG, no nasal tube, nothing. He went home fine, and he was fine, so we were fine. So this is another design that we did. So we said, okay, because the only problem that you sometimes face when you have a customized implant is the same problem that you also have when you do an AO plate, soft tissue. Soft tissue is extremely critical because if your implant is exposed, then everything goes for 6. At least in a reconstruction plate, you can take it out. But when you have a customized mandibular implant, there's a lot of cost factor also involved into it. And you can't do anything else after that. You just have to leave it plain. So soft tissue cover is extremely critical. So this is actually our 4th design. So we're making it more thinner. With more uses, probably we'll come up with better designs for reconstruction. So the idea behind this design is once you have placed the mandible, the patient goes home. 1 week after that, we see him.
and we open it up, and then we also, because this is made of titanium, so we print the titanium implants also. So custom-made implants, so you place the implant into the exact hole it goes and screws on, and then the process is designed, and the patient has his teeth, form, function, aesthetics restored. Not just for mandible, we can also do it, we also done it for the orbit, for orthodontic surgeries. Okay, in orthodontic surgeries, customized splint. Okay, a lot of surgeons, we know orthodontic, orthodontic splints is very critical when you do an orthodontic surgery. So what we do virtual surgery, once we move the jaw, the upper jaw and the lower jaw to the design that you wanted, your splint is set virtually. And once it's virtually set, all that you have to do is send it to the printer. The printer prints it in about half an hour's time, and then you have a splint exactly the same position as your upper and lower jaw is. And all that you have to do is just give the splint to the surgeon when he operates, and when he opens it up, it just fits like a T. Cranial implants, so this is one case that we did for the cranial implants, and see, this is the design for the cranial implant, customized implant. Soft tissue printing, bionic air, skin, all these are happening, and these will be a reality very, very soon. We have not yet started in India, but I think now there's a soft tissue printer that's started to come in the market in the US. It's just about $2,500 US. You can print cells. Same like how we use ink in a printer. Today, what they are doing is they're putting in cells in the printer cartridge. So that's how far technology is going on. It's high time. I know as surgeons, it's very difficult for us to come out of the usual strand of seeing blood and fibula, all these things for mandible. But today with technology, we can make it much better for our patients. This is probably one day we'll have babies born this time also. Okay. So the advantages for the surgeons, improving surgical planning, it acts as an orientation aid during surgery, it can enhance diagnostic quality, assist in pre-operative simulation, it's easy to achieve patient's consent during surgery, preparing a template for surgery for surgeons, providing an education tool for medical students and residents, increasing, we're not here all for charity, so sometimes it can also help in increasing your surgeon's income by increasing the number of patients. What does it do for a patient, most important? It's a state-of-the-art surgical technique, the ability for treatment options in an otherwise compromised treatment. Majority of procedures are covered by insurance and government schemes. When we started, we didn't know all that, but later we realized the government also covers a few of these options. So when the government covers it, then the cost factor is out. When the cost factor is out, we can do more for our patients. A chance for better life for most patients, and 90 to 100% restoration of patients' form, function, aesthetic. The reason why I put 90 to 100 is because no matter what best technology you use, ultimately it's the surgeon who's going to use them. So a surgeon's skill will differ from person to person, so that's why I said 90 to 100. So will 3D printing change everything? We hope it does change a lot of things. I'll just run 5 slides of the case that we did. This is our first titanium 3D printed patient. This was a 54-year-old male who came to us with ameloblastoma on the left side of the mandible. This was the extent of this tumor it was actually crossing over on the x-rays on this side also. So we said, okay, if he needs a resection, then the whole thing, we need to resect it right from this canine over here. I would give it about a good clearance, and on the posterior side over there. That's where we gave the clearance. Virtually, we did it even before we touched the patient. So when we did our planning of the designing of the implant, we started from basics, okay? First time we were doing it, so we drew how it was in school. You drew the mandible, where you want to make the cut, what was the best possible design that was there. Me and Dr. Karthik are 2 surgeons over there. We have an engineer with us, we have a lead designer with us. So this starts as a group where it's just not surgeons sitting on it. You have engineers. It's high time, I think, we start collaborating with people from other specialties. So we have engineers with us, we have lead designers on people with us. So we all sit together. We say, okay, what's the best option that's available, and what is feasible from a surgical aspect? Because I was in RP prototyping for 10 years, so with a little knowledge, a little bit better than the rest. So I said, okay, this was the best possible design that can be done. So it's easy for me to tell our engineer. My engineer designs with the tool that's available, and my lead design, he makes see that it's perfect. So in all analysis part of it. So we also are tied up with Anna University. in Chennai. So we send the design, whatever we did, to the university to go through a certain analysis. So there's no stress, strain, and we know it's all done to the proper way. This was the way we did the pre-op mandible, and this was the resection that was done virtually. Now, since this is done virtually, you also need to see that the same cuts also needs to be done in the surgical. So we made a surgical guide. We used the models for this, and these are the designs of the implant. This is the processes that we did, and these are the surgical photos. Can you just see the fit over here? Exact what we planned virtually was there when we opened it up. And all the readers used an extra oral incision, opened it, and then we had to close it over there. Finished over. This is 1 week post-op X-ray, 1 month. We just did it about 2 months ago, so we're giving it about 3 months proper for us to go on publication. So we said, and after that, then we'll talk about it. So this is what we do. So welcome to 3D printing for all your reconstruction needs. It's just not just the mandible that can be done, any part of the body. We also are working with orthopedic surgeons for replacing customized joints, and with neurosurgeons also we have a team working over there. Slowly we'll look at the other parts of the body also. Thank you. This is our motto. But whatever we do, we try to move forward. Thank you.
Thank you, Dr. Neeson. Perhaps there are some questions. We have a question. We have 2 questions. Do I hear 3 questions? Please.
Thank you, Doctor, for this very nice presentation. But I want to ask you about your ideas about limitation of your technique. What are the limitations of your technique? Can you perform it with every patient, regarding if the patient is planned to take radiotherapy after surgery or chemotherapy or something like this?
You can't do it. This is for.
I think you have changed the process from having the intraoral studs to have it in a second procedure, which really is nice. But I want to ask you, how can you open and for connecting the intraoral studs in the second procedure at the same place exactly? Okay. Do you use conventional procedure of long flap or punch technique? And if you are going to use punch technique, how can you determine the position of the head exactly? And if you are going to use this technique for the maxilla, can you make this implant of the maxilla with the nasal side and oral side both together, and with a hollow to reduce the weight, or what your plan is?
Okay. The case that we did right now, we are working only on benign tumors. We're not taking malignant tumors because, yes, the issue of recurrence is also there. The issue of if it's a recurrence or if it's an irradiated jaw, then we don't know how much of vascularity is going to be there. So we're not taking malignant tumors or irradiated jaws at the moment. But other than that, all other lesions, benign conditions and traumatic conditions and congenital conditions can be taken. I didn't show photos of congenital ones that we worked on, where we are actually designing the TMJ process along with the condyle also. So those are also started now. Those can be done. The question with respect to the studs, opening of that, we are planning to do it with lasers. So the idea of creating these holes, that's why the soft tissue cover is just adequate enough to cover across over there. And once you located it, because when you have a soft tissue cover, these insert holes that we have are going to be pretty soft. So all that we have to do is just take a laser, like how you do open an implant when you have a jaw in a mandible. We just laser the whole thing out very gently, and then these are customized implant. This is already an implant, then you have a customized regular dental implant, which actually just fits in over there. So this is screwed inside, and that's the way we planned for this design.
Dr. Tolar.
In the maxilla, I have 2 designs that we have done for the maxilla. Just come again for the maxilla, where you wanted it, sir? Correct.
And you need to make a very bulky implant to reconstruct both cavities together. And this bulky implant would be very heavy for the maxilla.
No, no.
Unless you make it somewhat
Correct.
hollow, but at the same time watertight.
For the maxilla, see, I'll show you one of the resection maybe once I come over there. Yeah. For the maxilla, it's very, very thin. Already the implant that we designed is 20 grams. The first case that you saw, 20 grams was the weight of the mandibular implant. For maxilla, we wanted to be 10. That's the maximum weight. We actually have a different design for the maxilla where you don't do the whole maxillary design as such. What you do is we planning to do just a small rod that goes in a square block with implant holes. This should be maximum weight about 7 to 8 grams is what we have planned. And then you have implant studs which can open it. So once implant comes in, the processes will have to be designed like how we do a regular obturator. So those are the ones that we are planning. But because it's not the regular way you process your obturator, we can 3D print the obturator also with the exact skin color, the teeth color and all. So those can be just screwed in like how we fix a dental implant.
So, if
Yes.
we have another question waiting. Yeah, Dr. Talat.
Mirek Talat, San Francisco. I want to congratulate to wonderful presentation and a wonderful piece of work.
Thank you, sir. Thank you.
And I can have questions later. Now I want to comment because it's wonderful to have a scaffold which is in fact reflecting in 3 dimensions the shape.
Correct.
Right? We have 3D imaging, we have 3D printing. Now we have to design the tissue regeneration.
Correct.
And for that we need stem cells.
Yes.
And we need vascularization.
Yes.
And both, I would even stress that vascularization is critical.
Okay.
So that it should be achieved in time. And because we are dealing with thick layers of the tissue. And even when we use stem cells, these stem cells should survive. And it is, in fact, time frame of 1 day.
Correct.
Okay? So you introduced, or you said there is a bioprinting on the way.
Correct.
But I still, we don't have it now. Okay?
Yeah.
And there are already successful regeneration, well, patients with ameloblastoma treated with stem cells and vascularization was achieved.
Okay.
So I want to congratulate, I will be talking about it tomorrow.
Thank you. Soft tissue, it's still 5 years. I mean, the official time which Lake Forest is given is 5 years. So can be a little bit later, can be a little bit more. But that's a lot of research has to go into it. A lot of legalities has to go into it. It's still the future. But other than that, as of now, materials are available. You can 3D print titanium. You can print most of the other materials possible.
Dr. John, you've stimulated a lot of thought and conversation here. We have another question. Yes.
Thank you for the good presentation. I want to ask about the situations where the technique is contraindicated or cannot be used.
Which?
The situations where the technique cannot be used or contraindicated. If there is?
This, where it can't be used?
No, the situation where the technique cannot be used.
I can tell you where it can be used.
No. Now we know the how when the technique indicated.
Correct.
But we want the adverse thing when the technique cannot be used. This situation cannot be used. This technique.
Okay, for the mandible, you can't use it, like I said, in case of a benign tumor. You can, malignant tumor. You can't use it.
Okay.
You can't use it if the bone. See, you need bone for it to hold. So if the bone, the adjacent or surrounding bone is soft, you can't do it. We can't also use it in a growing mandible because for kids that you're talking about, we can't use titanium, these kind of specific customized plate because growth is going to interfere, or if it grows, then the whole shape is going to change. It will fall off. So there we can't use it. And you need to have proper soft tissue cover. Because if you don't have primary soft tissue cover, then you're going to take another, it's a second surgery again, so you might as well go in for the fibula.
Okay, thank you. What about the joints? You said the joints, there is some...
For TMJ, we are working on the, see right now, I mean, Dimitriolus, I think 2 months ago did the first TMJ printed joint, so it's there. The way we are doing joints is, we are designing the condyle along with the ramus part of it. So along the condyle head comes along. For the glenoid process, what we're doing is, the glenoid comes with a specific stud. It's a ready-made stud that comes. Between the glenoid and the condyle that we have, okay, because you have, in case of a normal bone that you have, this is a metal titanium. You can't be going, it can't clash along with normal bone. So there's always going to be either wear and tear of the bony part, or sometimes if, let's say, the patient is going to bite something hard, there's always a chance of this going into the glenoid. That's a soft bone. So what we do is we design the glenoid implant also so that it holds this mandibular component, and in between the mandibular component and the glenoid, there is the joint made of high density polyurethane, nylon. So that's, right now it's been patented by Martin, KLS Martin. So nylon can be printed also. So we're seeing how we can take that material, the high ultra density polyurethane, and place it as a small layer between the condyle and the glenoid process. So whenever there is the mastication and movement of the mandible, it doesn't hit the glenoid directly as such.
Thanks so much. Thank you.
Further questions? Excellent discussion. Delegates, please join me in thanking Dr. John Nissan.
Thank you.